Okay.
Hello, Yo. Dr. Michael Gibson is in, okay?
Yeah, okay, thank you. Okay, we can start. We can start the technical support team.
Yes, please, Associate Partner Hồ Thường Dũng.
Okay,
please.
Ladies and gentlemen, welcome to our virtual meeting held by Vietnam Society of Interventional Cardiology and Thống Nhất Hospital, particularly in cooperation with the faculty from the USA. Our topic today is very interesting. Optimal complex bifurcation PCI. I think the topic is very interesting and very useful for the Vietnamese interventional cardiologists. I am Dr. Hồ Thường Dũng, President of Vietnam Society of Interventional Cardiology, Vice Director of Thống Nhất Hospital. And my co-chair, Professor Trương Quang Bình, Vice Director of University Medical Center. But today, Professor Trương Quang Bình, he is busy because, as you know, COVID-19 pandemic is outbreak in Vietnam, particularly in Ho Chi Minh City. And yesterday, Dr. Trương Quang Bình was assigned to found the new therapeutic center for the severe patient. So today he's very busy to prepare for the new center. So we will see you in the next session. So in replacement for Professor Trương Quang Bình, Dr. Vũ Hoàng Vũ, Director of Interventional Cardiology Department of the University Medical Center, will replace Dr. Trương Quang Bình. And we have three faculty of the Vietnam team. The first Professor Nguyễn Văn Tâm, Associate Professor of Medicine, Director of the Interventional Cardiology Department of Thống Nhất Hospital, and Vice Director, Geriatric Department of University of Medicine and Pharmacy, Ho Chi Minh City, Vietnam. And the second, Dr. Ngô Minh Hùng, Vice Director, Interventional Cardiology Department of Chợ Hospital, Ho Chi Minh City, Vietnam. And the last, Dr. Đinh Đức Huy, Director of Cardiology, Tâm Đức Hospital, Ho Chi Minh City, Vietnam. And today we are very pleased to be joined by faculty from America. I would like to introduce the faculty of US team. The first, Dr. Thạch Nguyễn, he is the co-chair with us. He is the senior of the most of interventional cardiology in Vietnam, big brother. Dr. Thạch Nguyễn, Director of Cardiovascular Research Laboratory, Methodist Hospital, Murrayville in USA. Academic Dean, Tân Tạo University School of Medicine, Long An, Vietnam. The second, Dr. Michael Gibson, Professor of Medicine, Harvard Medical School, President and Shell BAM Institute for Clinical Research. Interventional Cardiology, Pell Israel Deaconess Medical Center, Boston, MA, USA. The third, Dr. Duan Pinto, Associate Professor of Medicine, Harvard Medical School, Chief of Interventional Cardiology, Director of Intensive Care Unit, Beth Israel Deaconess Medical Center, Boston, USA. And the last, Dr. Sandip Nathan, Associate Professor of Medicine, Medical Director, Cardiac Intensive Care Unit, Director of Interventional Cardiology Fellowship Program, Co-Director, Cardiac Catheterization Laboratory, the University of Chicago Medicine, Harvard and Heart and Vascular Center, Chicago, USA. Now we can start our session. The first, I would like to invite Dr. Michael Gibson give a welcome remark from the US team, and he give the first presentation. Please, Dr. Michael Gibson.
Well, thank you so much for having me again. It was a few years ago that I came to your country and lectured and also did cases. It's an honor to be back with all of you again. Thanks for having me tonight. Thanks for having Dr. Pinto tonight from our institution. I know Dr. Pinto has visited you as well. Well, I'm going to talk about the patient who has both atrial fibrillation and a stent. Do I need to share my slides? Or are you going to share my slides?
Yes, please, Dr. Gibson, please share on your side, please.
Okay, I will share my slides. Great. Can you see my slides?
Yes, very
Yes,
well.
very
Great.
clear.
Okay, so we're going to talk about how do we manage the patient who has atrial fibrillation who's getting a stent. A lot of controversy here. I have research grant support from all major manufacturers of antiplatelets and antithrombins. Here's the overall strategy, and this comes from the 2020 guidance from the European Society of Cardiology. Basically, every patient's different. You have to balance the risk of bleeding and ischemia. We are cutting way back on aspirin. Aspirin is given really only up to discharge or 1 week or 1 month, depending upon the risk of bleeding. And we don't have data on ticagrelor and prasugrel. So we use largely clopidogrel in this setting. So people will get a NOAC plus clopidogrel for either 6 months or 12 months, depending upon whether it's chronic disease or ACS. Let's talk first about ACS. In ACS, you're going to give about a week of aspirin, maybe up to a month if there's very high risk of stent thrombosis. Stop the aspirin, and then, if possible, continue clopidogrel for 12 months. That's ACS. Early stop aspirin, clopidogrel 12 months. Chronic coronary syndrome, again, drop aspirin very early at discharge or up to a week, very early stop aspirin, and give clopidogrel up to 6 months, not a year, but 6 months, and continue the NOAC. So again, let's talk about a patient who has ACS. On the left, is the default strategy: stop aspirin early and continue the NOAC plus clopidogrel for 12 months. But if someone has high bleeding risk, you're going to stop the clopidogrel after 6 months. Stop aspirin at discharge, clopidogrel off at 6 months. If someone is at risk of stent thrombosis, you can continue the aspirin for 1 month and then continue the clopidogrel for 12 months. That's the overarching strategy. Why are we dropping aspirin? Aspirin causes a lot of bleeding, causes a lot of GI bleeding. It actually can cause some vasoconstriction. It's not as potent. It is not as potent as clopidogrel, and we see lower is better in some studies like Plato. When you look at all the studies that have been done recently, all of them come to a very similar conclusion, whether it's Woost, Redual, Augustus, Pioneer, which I led, Global Leaders, Twilight. Let's look at Twilight. That was one of the more recent ones. You had 4 months of DAPT, and then you either got ticagrelor with aspirin or ticagrelor alone. And all of you probably know ticagrelor alone, less bleeding, as you would expect, but no difference in ischemic outcomes, didn't improve outcomes by adding aspirin to ticagrelor. In the Pioneer study, in people with AF, I found something similar. By getting rid of dual antiplatelet therapy early and by replacing warfarin. Warfarin is the top line, high rates of bleeding with warfarin and triple therapy. We can reduce the risk of bleeding by getting rid of warfarin, using a NOAC, and stopping aspirin and clopidogrel earlier. The bleeding that we stopped was not just nosebleeds. The bottom line shows that many of these were fatal bleeds. There was a higher risk of fatal bleeds with warfarin and dual antiplatelet therapy. By getting rid of warfarin, by not using triple therapy, there was no difference in the risk of ischemic events either. And this is the conclusion of all the studies of replacing triple therapy with a NOAC plus a thienopyridine. All of them showed less bleeding, less ICH, and no difference in major adverse outcomes. So I think the world has really settled in on getting rid of triple therapy, no more warfarin plus DAPT. We now recommend NOAC plus thienopyridine in these patients. But again, the decision will depend upon the bleeding risk of the patient. Well, thanks for having me back. I really loved visiting Vietnam. I love seeing Hong Long Bay, love going to your hospitals. Thanks for having me back again. And thank you, Thak, for arranging this and inviting me.
So thank you, Dr. Michael Gibson, about the very condensed presentation about the antithrombotic and antiplatelet therapy with the stent for the patient PCI. So, and any comment from the panelists in the in this presentation from Dr. Michael Gibson. So I have one question about the therapy of the AFib and the PCI, because we have to keep the balance between the risk of ischemic and bleeding risk. And how about the intravascular, for example, IVUS and OCT to optimize the result of the stenting, and maybe we have some benefit in the therapy after that with stop admit or something like that. What do you think about the intravascular imaging in this situation, high bleeding risk and also high ischemic risk? And thank you.
Yes, excellent question. You know, I think throughout the world, particularly in the Pacific Rim, you're doing a great job with intravascular imaging. And, you know, that may explain the Pacific Rim or Asian paradox, where you have much lower rates of stent thrombosis than what we have in Western countries. At our hospital, under Dr. Pinto's direction, we have greatly expanded the use of intravascular imaging, making sure that we are well opposed and we don't have any edge dissections, and we've really optimized things in our lab. So yes, we are stopping aspirin very early now in these people. And even if you don't have AF, we're stopping aspirin probably at around 3 months. Shorter and shorter durations of aspirin. But you must make sure you have a technically very good result. And Asia has really led the way in pioneering the use of all the intravascular imaging techniques. Thank you for leading the way.
I have one question for Dr. Michael Gibson. Today, our topic is complex PCI. It means the patient of the chip or complex PCI is at very high risk for a thrombotic event or ischemic event. So how about your advice or recommendation about dual antiplatelet therapy for this kind of the patient, and the role of the potential antiplatelet such as ticagrelor or prasugrel? It can replace for clopidogrel in dual antiplatelet therapy, please.
Well, often we worry about bleeding, but in the CHIP patient, we are worried about thrombosis, as you say. And if someone can tolerate antiplatelet therapy, I would give a full year. I think you mentioned prasugrel. I led the trial, the Triton trial of prasugrel at Triton TIMI 38, where we showed better outcomes with prasugrel. Of course, you know, recently prasugrel showed it was superior to ticagrelor, so it's a very reasonable choice. I know your dose of prasugrel is lower and is probably safer for that reason than what we get in the Western world. So I think your proposal of aspirin plus prasugrel for a long period of time, maybe up to a year for the CHIP patient, is probably a very good choice.
So thank you, Dr. Michael Gibson. So today's topic is about the optimal PCI of bifurcation. So I have one question about the PCI for the bifurcation in the patient with the AFib. We think about 2 stent or 1 stent surgery. How to balance between the ischemic risk and bleeding risk in the patient with the bifurcation for the interventionalist. Thank you.
Yes, again, in that patient, I would be very aggressive if possible with dual therapy for longer, just like before, prasugrel at your dose for a year, and aspirin would be a very good choice in the bifurcation patient. Guided by ultrasound and OCT, though. You do a great job with that in your country.
So thank you. Dr. Hui, what do you think about if you have the AFib patient and you have the bifurcation lesion, we have to do the PCI. So what do you think about the how many stents you put for this kind of patient? What do you think?
mean of bifurcations, and then we definitely to fix the bifurcation place. So I think if we it depends on the anatomy of the bifurcations. We all agree that now one stent technique should be our first choice for implanting stent for bifurcations lesion. But anyways, I think there's no just one rule for all bifurcations anatomy. It depends on how severe is a branch, how big is it, and then we can choose one or two stent technique for the lesions. So Dr. Gibson, I also have one question for patients with AFib. How soon will you start your NOACs after the PCI? First day, 12 hours after the procedure, first day or second days, or to be discharged?
Well, we, often if they come in on a NOAC and it's a non-STEMI or emergency, we'll do the case on a NOAC. If it's a stable patient, you might discontinue the NOAC for a day before, but we start the NOAC up right after the procedure. We generally don't preload at our hospital. We give, with the thienopyridine, we give thienopyridines on the table or use Tangalore. But again, in the duration, the NOAC is going to be for forever because they have AFib. Shorten the aspirin, and then 6 months or 12 months on the clopidogrel is probably our recommendation.
Yeah, I have one question similar to Dr. Đinh Đức Huy for Michael Gibson. For example, what do you think about the switching of the antithrombotic therapy for some VKA or NOAC after the procedure, or you keep the same antithrombotic therapy compared to the before the procedure? What do you think about that? Thank you.
Yeah, good question. There's lots of choices. They're all very good. You can give full dose apixaban with short aspirin and clopidogrel. That's one choice. Or you can give reduced dose rivaroxaban plus clopidogrel. And by reduced dose in our country, that would be 15. In your country, that would be 10 of Riva. So cut down on the Riva, give clopidogrel, or go full dose apixaban plus clopidogrel. If someone's at risk of bleeding, I go with 10 of Riva plus clopidogrel. If someone is not at risk of bleeding, full dose apixaban plus clopidogrel.
Thank you.
We don't have cangrelor in Vietnam. So what is your opinion if we get the cangrelor here? Is it any role of cangrelor of ACS patients and AFib?
I'm sorry, Dr. Hui, you don't have what in your country?
So far, we only have Pasugrel and Ticagrelor.
You don't have clopidogrel.
No. We have clopidogrel. We have Pasugrel. We have Ticagrelor. So if we in the future we have cangrelor, the IV.
Cangalor. Yeah. Well, I use Cangalor. We don't preload. The data for preloading, no randomized data supports preloading prior to the cath. Dr. Pinto and I have a famous picture he took of the pills sitting in the esophagus during the procedure, not in your bloodstream. So I give Cangalore in many cases. If there's ACS or visible thrombus, Cangalore is a good choice. If you don't have Cangalore, though, you can give crush ticagrelor, and full load 180 of ticagrelor crush at the time of PCI if you don't have Cangalore.
I have one question for Dr. Michael Gibson. Thank you for your excellent presentation. So as you know, most of cases from the ACR or especially in the Vietnam now optimal PCI without imaging. So do you think 1 month, 1 week to 1 month is enough the time for optimal DAP or triple therapy? And recommend in this situation?
Yes. So if someone is the default strategy in general, stop aspirin at a week. If then continue clopidogrel in ACS for 1 year, stable syndrome, continue for 6 months. NOAC forever. If there's no AFib, then stop aspirin maybe at 1 month, and I'd stop clopidogrel in non-ACS at 3 months. Non-ACS, 3 months clopidogrel.
Okay. Thank you.
Mm-hmm.
So I have one question about this topic for Dr. Phạm Ngô Minh Hùng, because he doing a lot of rotaplator case. So so how about the triple therapy for the case with rotablation? Is it different from other case? It's the same. Thank you, Dr. Hùng.
Well, you get a lot of thermal injury with rotablation and a lot of intimal disruption. So very important in those cases.
Yes,
Be aggressive. Yeah.
Yeah, Dr. Wu asking me about the triple therapy when we dealing with the complex PCI. So I think it's quite the same answer with the answer from Professor Dũng, that we do a lot of chip procedure. So we have to calculate that the patient can tolerate with the long-term triple therapy or not before we dealing with that. Otherwise, when we start in the after finishing the procedure with the very complex, so we cannot stop using the triple therapy, so we will in trouble. So before doing that, we have to calculate that the patient can tolerate with that kind of long-term, at least 1 month or 3 months before we start doing the chip procedure. Thank you.
Thank you, Dr. Hùng. So any comment from the panelists, please? No? Okay. So to summarize the first lecture from Dr. Michael Gibson, I summarize something. The first one, if we have the patient with the AFib and we have to do the PCI for this patient, we have to keep the balance between the ischemic risk and bleeding risk. The second, the anticoagulation I think we prefer the NOAC better than the PKA. And the third one, P2Y12 inhibitor. The Crockwell is I think is a good choice for us now. I think it's a prefer P2Y12 inhibitor for most of case. Sometimes we use the ticagrelor or prasugrel. And intravascular imaging, I think is give us more confident when we stop when we face with the patient like this, high bleeding risk and also the high ischemic risk, and stop aspirin as soon as possible. I think it's a good choice for us when we do PCI with the patient with AFib. So the second lecture is from Professor Hồ Thường Dũng. He's the president of the Vietnam Society of Interventional Cardiology. So he will talk about the complex bifurcation PCI. How are we doing now in Vietnam? Please, Professor Thor Thiên Dũng.
Okay, thank you for your introduction, Dr. Vũ Hồng Vũ. And now my presentation today, the topic is the complex bifurcation PCI. What are we doing in Vietnam? And I like to introduce something about the phenotypic classification of complex bifurcation. What are the complex bifurcation? Of course, it belongs to the CHIP. CHIP is a mean complex high-risk interventional procedure or complex high-risk interventional patient. And about the CHIP, what patient we are talking about? The CHIP patient, they have a 3 characteristic group. The first patient have the comorbidity such as heart failure, or elderly, diabetes, renal failure, or high bleeding rate of frailty. The second group is about the hemodynamics, such as the low ejection fraction or aortic stenosis. It means the patient is very easy to fall into the ketogenic shock or acute heart failure. And the last is lesion characteristic. And topic my presentation talk about this bifurcation. It means the anatomy of coronary characteristics, and the bifurcation is one of the type of lesion characteristic. And according to 2020 position statement of the SKY, they talk about the complex PCI. They have the same, but they replace hemodynamic group by instrument. So our presentation here, bifurcation lesion, and this is the new replay hemodynamic for instrument we need when we perform complex PCI. Another 2020 SKY position statement, in this they present PCI risk stratification pyramid. The pyramid have a 3 level. The first level, the symbol A. A is mean ambulatory. It means the patient in the stable CAD without complication. The patient can be ambulatory. The second level is C. C is mean a complex comorbidity of complex PCI, and the highest level is E. E is mean extension, the cardiogenic shock or cardiac arrest. And my presentation it belongs to anatomy of coronary artery here, bifurcation. So complex bifurcation is anatomy of coronary artery, and we have a different anatomy, different localization, but always be challenged. And so far until now, there are many classification of scheme, such as the Friend, Dew, Chetian, Chengao, Mohammed, Sabon, and everybody very familiar with the Medina classification scheme. It's about the classification anatomy of bifurcation lesion. And I think this slide is very important for the young interventionists who like to challenge, who like to perform complex PCI. This slide talks about the feature of coronary bifurcation lesion. What are the difficult? The first, the true versus non-true. The second, the side branch, small or large. The third, the diameter difference, mismatch between the main branch and side branch. The fourth, tapering of main branch. The fifth, angle between main branch and side branch. The sixth, disease burden of side branch assessed for ostium of proximal segment. And seven, extension of disease in side branch. And the last, the tactical strategy, one stent or two stent. I think it's important for the young interventionists who like to perform complex PCI. And in this slide, we present the triangle, the definition to triangle. The definition to triangle talk about compare between the two stent strategy and versus provisional stenting in patient with complex coronary bifurcation. In my presentation, I then discussed about the result. A two-stent strategy may be better than provisional stenting subbrand, but I like to focus about the definition of complex coronary bifurcation lesion. In this area, I can present again. Complex bifurcation lesion, according to the definition to triangle, they have a major criteria and minor criteria. Major criteria, they have a major 1 and major 2. Major 1 is mean a left main bifurcation, and major 2 a non-left main bifurcation. And the minor criteria includes the first, severe calcification, the second, multiple lesion, the third, bifurcation angle, acute or obtuse. 4, main vessel reference vessel diameter, it means diameter is small. And the length of the lesion. And the last, thrombus containing lesion. And how we can define complex bifurcation. We need one major criteria plus any two minor. And if fulfill criteria, it's a complex bifurcation. And however, when we perform the many case with complex bifurcation, we have a one recognize. The complexity of bifurcation depends not only on anatomy of bifurcation itself, but also on the whole coronary anatomy of coronary artery tree. So we give the phenotypic classification of complex bifurcation. Complex bifurcation, it have defined true bifurcation of an important localization. How about the important localization? It means the bifurcation of the distal left main or position supplying a large amount of myocardium. Plot with red one the following. The first, severe calcification bifurcation. The second, sequential or tandem bifurcation. It means only two bifurcation. And the distance between two bifurcations shorter, more complex. The third, critical stenotic lesion nearby. Because if we have the critical stenosis nearby, it's very easy to induce acute ischemic crisis when we perform the technique. And it can affect to the step by step, you fulfill, accomplish two techniques, so on. Sometimes we must stop the technique and you can change, you can do out of the plan, and the last result are not good. The fourth, triple vessel disease. The fifth, a small diffuse disease. The sixth, thrombus containing lesion. And we consider clinical setting of acute MI, because clinical setting of acute MI not anatomy of coronary artery, but sometimes it is similar or the same to the thrombus containing lesion. The seventh, repeat revascularization of stentic bifurcation, particularly in the case of revered two-stent technique. The eighth, last remain vessel, and the last trifurcation, a quadrifurcation. If greater than 2 factors, it's very complex bifurcation. And I think this slide also important for the young interventionists who like to challenge to perform complex bifurcation PCI. And the next slide, we talk about the instrument. Instrument or equipment needed to perform the complex bifurcation. The first, we need intravascular imaging, such as IVERS or OCT. It's very important for the optimal PCI, such as Dr. Wu and Dr. Michael Gibson have a talk. The second, intracoronary physiology, such as FFR and IFR. The third, guide catheter extension. Sometimes we need microcat or hydrocele to expand the balloon or the stent to the lesion. The fourth, specific coronary wire. The fifth, specific balloon, such as the NC balloon, cutting balloon, and scoring balloon. The sixth, cover stent to show to many some complication coronary rupture. The seventh, atherectomy to manage the very calcification lesion. Rotablator, orbital atherectomy system, intravascular lithotripsy, or laser coronary atherectomy. The anti-embolic protection device, such as the filter wire, very important when the burden of thrombus, last burden of thrombus, such as when we do the PCI to saphenous vein graft. 9, the mechanical cardiac support, balloon pump, impeller, ECMO. So in the Vietnam, at present, what we have, the first, we have an IVERT, we have an OCT, but not very common, not very available. Just some the cath lab in the big cities, such as Ho Chi Minh City, Hanoi Capital, Huế, Da Nang, so on. The second, intracoronary physiology, FFR and IFR. We have FFR, we have IFR, and the same situation with the intravascular imaging. The guide catheter extension, we have all, every. The specialty coronary wire, we have all for CTO. PCI, specialty balloon, we have all. Cover stent, we have to manage the coronary rupture. Atherectomy, we have only rotablator now. I don't know which cath lab have a more instrument. Embolic protection, we have filter wire. Mechanical cardiac support, we have balloon pump. We don't now have a impeller, we have an ECMO. So if some cath lab or some interventionist have a plan to do the complex bifurcation PCI, you should prepare for equipment. So by now, we have some demonstration for complex. By now we have some demonstration for some complex bifurcation. The first complex bifurcation PCI, the triple vessel disease in acute MI. Before the interventionist line to do PCI to the complex bifurcation, we should analyze the coronary angiogram to consider the factor of complex bifurcation. In this patient, they have a important localization. It means the left main bifurcation. They have in acute MI activity. This you can see. Distal left main on a small diffuse proximal segment of LAD and circumflex. And the lesion in the right coronary artery. So when we do the analysis of complex bifurcation, the patient have one factor left main. It means important localization in acute MI, a small diffuse, and triple vessel disease. I done I don't go deep into the technique. I think the presentation of Dr. Ngô Hùng will present one case with very detailed in the technique. We present the result. Pre-PCI, both PCI with the two-stand technique, pre-PCI, both PCI. Pre-PCI, both PCI. We can see with the two-stand technique, we can manage this case successfully. And the next case, complex bifurcation PCI with trifurcation phenotype in a QMI. This patient have a three-factor left main bifurcation, trifurcation in acute setting. You can see trifurcation, the left main trifurcation. And this is the result. With you, the technique not double kissing, the triple kissing balloon. So in this case, we have the patient have a 4. The patient have a 4 factor for the phenotypic classification. The first important localization is left main. The second trifurcation. The third acute setting, non-STEMI, and the last triple vessel disease. And the next one demonstration for complex bifurcation of PCI with the sequential phenotype. Now, you can see the bifurcation lesion in the distal left main, and we have another bifurcation between LAD and diagonal. So in this patient, they have 4 factors. First, important localization. The second, the sequential bifurcation. The third, the triple vessel disease, and the 4th, acute setting. And this is the result. And in the case of sequential bifurcation, the distance between the two bifurcations is very important. If it's long, it's no problem. But it's shorter, more complex when you do the technique. The next case, the sham. The factor is the important localization in left main sequential bifurcation. And in this case, particularly many critical stenotic lesions nearby. Dr. Vũ and Vũ will familiar with this case because I do this case in the University Medical Center. And because it have many critical stenotic lesions nearby, so when we perform the PCI, there are many acute ischemic crisis happen. I present the last result. We can see here the critical lesion here, and it induce very difficult when we perform the PCI. And the next for demonstration complex bifurcation with the severe calcification phenotype. The first left main bifurcation, and as you see, a very severe in proximal segment of LD. and triple vessel disease with the critical and long lesion in the right coronary artery. So the patient belong to the very complex bifurcation lesion because they have the first factor, the left main, the second severe calcification of bifurcation, the third triple vessel disease. And in this case, we must use atherectomy for the lesion in the LDD. And culprit lesion in the circumflex. One more case with very calcified bifurcation for demonstration. In this patient, the patient first, the factor important localization. The second, severe calcified bifurcation. The third, repeat revascularization. This patient will perform the PCI many times in Vietnam, in Singapore. I think at least 5 or 6 times with three bioabsorb vessel scaffold and three DAS. And the patient come in with acute heart failure and cardiogenic shock because one lesion severe very calcified in the ostium and extend to the distal left main here. And you can see flow of the LD and CTO in the right coronary artery. It means one more criteria large remaining vessel. When we do PCI to the left, it's a very, very high risk for hemodynamic compromise. And in this case, after we pre-dilatation by balloon, we can do IVUS. You see, and the lesion gastric the IVUS, so we must manual put back. We can see some very calcification, 2/4, sometimes 3/4 calcification around the lesion. And this is a culprit lesion. Culprit lesion is proximal segment of LD, and it go into the left main. In this case, upscore, we must do atherectomy router later. But we don't have the big burr. We have only 1.5 millimeter. In that time, we do the PCI. So pre-PCI, post-PCI, pre-PCI, post-PCI, pre-PCI, and post-PCI. The calcified lesion not expand fully because after we do router later only with the burr 1.5 millimeter, and after that we do more the scoring balloon or cutting balloon, but the lesion cannot fully expansion. But I think it's rather good. And this one case for the demonstration, repeat revascularization. Repeat revascularization many times, many stents, and the patient were hospitalized in the acute setting, look like acute heart failure and look like cardiogenic shock. The patient have an important localization left main thrombus containing lesion, repeat revascularization many times, many stents, and a triple vessel disease. The patient come in with the severe hemodynamic setting. As you see, can see slow flow all the left coronary artery and some stent. We can determine exact how many stents. It can cover from the left main to the LAD to circumflex. You can see, and some thrombus. It about the artery with the severe lesion here. I don't go deep into the technique, but this is a PCI. But in this case, when we do a wiring, very difficult because we must go through the many stent and the restenosis and thrombus. After we do the PCI, the hemodynamic becomes stable, and by now he is okay. Pre-PCI, both PCI. And by now, I like to the demonstration for, how about my time? Okay. I like to the demonstration for some case with the trifurcation and quadrifurcation. The first, the trifurcation. Here. Pre-PCI. I'm sorry, the result of what PCI and not can because I'm not time for insert. This guy very special qualification. The patient was sent from another cath lab. As you see, this left main with 4 branch. And you can see in the distal left main, when we go, when we wire into the circumflex, very difficult because the very acute angle and some calcification here. And we have the critical lesion nearby the bifurcation lesion. So in this case, very complex. And we try to do the PCI because, and in this case, this is the last vessel remaining vessel because the CTO in the RCA and the patient refused bypass surgery many times. So after we do explanation to about the very high risk, about the successful rate, not high, and very high risk for complication. The patient also choose intervention, and we try to do. And this pre-PCI and both PCI, pre-CI and both PCI. So I go to a conclusion of my presentation with some take-home message. The first complex bifurcation identified as the true bifurcation of important localization, often the left main distal left main with greater than one of factor of phenotypic classification. The second, the goal of the PCI is treating bifurcation lesion is optimal the result and optimal the physiologic patency of side branch. The strategy of complex bifurcation should be not only the individual anatomical bifurcation feature, but also on the phenotype of the complex bifurcation, even the whole coronary artery tree, not only bifurcation anatomy. And the fourth, intentional two-stent technique may be associated with a more favorable outcome than provisional side branch stenting, particularly for the complex bifurcation. And the last, more attention should be paid to optimize the chosen technique than chosen among technique. So you can choose any technique familiar with you, but you should optimize the chosen technique, then choosing among technique, one or two or three, DK cross or Q loss or TIB, so on. And the last, the cataract interventionist who like to perform complex bifurcation, he should familiar with two-stent technique. He should familiar with intravascular image, familiar with intravascular physiology, and with atherectomy with some instrument, particular for chip. Thank you so much for your listening.
Well, that was amazing. I'm just so impressed with the complexity of what you're doing and the amazing results you're obtaining. I'm going to turn this over to Dr. Pinto, who's going to ask a fair number of questions. I've also been following what's going on in Vietnam with COVID. You did a great job avoiding a lot of infections early on. I see that Delta is infecting Vietnam now. I know you're still going to be in lockdown in the southern part of the country. I see that you're using disinfectants. I'm happy to see 4 million people vaccinated. I know you have many more that you need to get vaccinated. I hope your country will do better than we did in getting a lot of people vaccinated. I know the numbers are rising. We had a very tough time in our country, and in particular in Boston. My thoughts are with all of you. Please wear your masks. I still think even if you've been vaccinated, I still wear my mask. In our country, in Massachusetts, we had one outbreak where 3/4 of the outbreak was in vaccinated people. So vaccinated people can spread Delta. So wear your mask. I hope you get as many vaccines into people as you can. And Dr. Pinto and I will be thinking of all of you.
Thank you, Michael.
I'm going to turn it over to Dr. Pinto now. Dwayne, are you on the line?
Yes, can you hear me?
Yeah, there you are.
Hello, Pinto.
Hi, how are you, my friends? It's been so long that I've been able to see you, and it's good to at
hello,
least
Dr.
see you.
Pinto, Dr. Hong from Cherai Hospital. 10 years now, Dr. Pinto.
Yeah, well, you see, my hair has become gray, but all of you have not developed any gray hair.
Yeah. Happy to see you again.
Yes. Well, you know, those were, as Dr. Gibson said, those were amazing cases. I think that the summary of Professor Ho was right spot on, that you know, you really need to get familiar with several techniques and really be a detailed connoisseur of each of the steps. And I think you rightfully say that DK crush, culotte, and tap are the three main techniques that all interventional cardiologists should master for bifurcations. In that way, I think you can handle 99% of bifurcations and handle also the bailout strategies and the different morphologies that we are faced with. I like the toolbox, what was described, particularly with regard to atherectomy and lesion imaging and preparation. I think that is very key in the diffuse disease like the ones that you saw that were shown, and the remarkable, quadrification left main was amazing. I do think that, we have to do a better job as interventional cardiologists for the left main and the proximal LAD, because that is where the surgeons do better than us with the lima. And it's because we're doing inadequate PCI at times. And that's where intravascular imaging and lesion preparation can help us obtain a better result. I will say that I might add to the toolbox something that I've become very dependent upon for my procedures is the guide extensions, as well as microcatheters. And the guide extensions in particular, the trap liner, we have ability to trap wires and equipment. It makes the procedure so much faster. And then also with regard to wiring difficult bifurcations, I like the Sasuke catheter, but also wiring side branches, for example, in the culotte or DK crush, or even the tap can be very difficult at times. And I find a microcatheter allows me to change the wire and the wire shape very rapidly. But I would like to hear from my other colleagues, maybe your favorite tip that was not mentioned in this presentation for the left main. I'll go first. I find that osteal disease is a different kind of left main than distal or shaft left main disease. You really need a lot more radial strength, and I think there's more recoil. I think it's really aortic disease, just like the subclavian or the renals or the mesenteric vessels. So what I've been doing is being more aggressive about predilation in the ostium with cutting balloon or atherectomy, because I find that even though the balloon expands in some cases, when I put the stent in, there's a lot of recoil in some cases. So that's my tip, is for osteal left main disease, is to be more aggressive with the predilation and perhaps a scoring balloon.
I have one question. When I perform complex bifurcation PCI, I'm afraid very much. I feel very difficult when I do repeat revascularization with the stent, reverse stent in the very calcified lesion, and the previous stent not under expansion. And after that, in-stent restenosis and under expansion. When we repeat PCI again, very difficult, particularly in Vietnam. We cannot use atherectomy rotablator. I see in some interventionists in America, in the US, use rotablator to apply the under expansion stent. But in Vietnam, I think I'm not feel confident to do that. How about you?
I would not rotablade. I mean, I've done it and become very scared to do it, is a fresh stent. But I think a restenotic underexpanded stent is okay. But for the underexpanded stent, my preference actually is laser atherectomy. Because I think the acoustic wave as well as the ablative force is better for neointima, if that's part of the problem. But for underexpansion, I think being able to expand the stent, our usual has been laser. Of course, lithotripsy is not approved for in-stent restenosis, but I do think that this might be a better treatment, or easier treatment at least, to try if it certainly is calcified in-stent restenosis. But getting back to the first statement, we really shouldn't be putting in these underexpanded stents in the first place. So I call upon us as a community to do better. because you have to clean up these messes later, and the patients have to suffer with restenosis and recurrent angina. And once you've put one layer of stent in, it's probably over after 2 layers. We should not be putting 3 layers of stent in and these sorts of things. So we really have 2 shots at this to get it right. And I think we have to do a better job at the beginning.
Yeah, in Vietnam, when we encounter some difficult case with 3 PCI look like that, if we don't use more stent, we cannot open the under expansion. But if we put one more stent, it's very terrible. The patient after
Terrible.
some month, some 1 year, they come back and we cannot do anything.
You see it on the imaging, this like onion skin of smaller and smaller stent, and it's just terrible for the patient.
Yeah, I'd like to hear some experience or some comment from the faculty or from panelists about your experience.
Can I ask? And also for Duane, do you routinely use IBP ECMO for patients with left main high risk before PCI?
Yeah, in the case with very high risk, such as some case I perform. Yes, I have only balloon pump standby, and in case very high risk, I put in advance one sit in the left femoral artery, and if the hemodynamic compromise, I use a balloon pump, only balloon pump in Vietnam. By now, we have not impeller.
Yeah, I don't use the balloon pump anymore because we have the luxury of having Impella. So I will say that not every left main, not every last remaining conduit requires Impella. People with impaired LV function, people in decompensated heart failure, or people with, particularly if you're going to be using atherectomy, that's where I would prefer to use mechanical support. I don't use ECMO because unless the person has arrested, and so it's a load on the ventricle, it's really just to keep the rest of the body alive. So, I don't use ECMO. I believe also too, in these left mains, when somebody gets hypotensive and their blood pressure is 50, the balloon pump isn't doing anything anyways. 10% of 0 is still 0. So, to me, if you're going to do something, for us, I have luxury, right? I can use Impella, but I don't use it in everybody. And if I have a question, I'll do a right heart cath. And if they have elevated filling pressures, low cardiac output, and they're sick, then I'll do it. If I'm unsure, I'll do what Dr. Ho said, is I'll put a small sheath in the other side, and I can very rapidly put in an Impella in if the person starts to get sick. You just have to be willing to do it. You say, oh, no, I'll put the stent in. Oh, I'll post-dilate. Oh, yeah, maybe and then you don't do the imaging, and then you don't do a good job. So in the end, you have to be willing to do it. But the other is the patient with aortic stenosis. It's a relative contraindication, and people always worry about it. But, my strategy is then to put a pigtail in the ventricle. And then you can monitor left ventricular diastolic pressure. And then if the person gets sick, you just exchange for a TAVR wire, put the big sheath in, and then exchange for the Impella wire. And it takes 1 second, even with aortic stenosis. So again, I know it's very difficult in Vietnam because you don't have widespread access to it. It's so expensive. But we've lost patients, certainly. And I'm sure you have too, with left main disease who come in very sick. And I, again, say I'm thankful I have this device, and I don't really have to use the others. But for you guys, I think if you have a really sick person, you have to use ECMO. I mean, that's what you have. And then, you have to be just as good at large bore access for ECMO as for, Impella.
I never use ECMO. I don't have experience about ECMO. How about Dr. Ngô Minh Hùng in Chợ Hospital? How many case you use ECMO?
Yeah, thank you for asking the question. Actually, I totally agree with Dr. Pinto, my friend, about the IBP when the patient is so sick. So we don't if we use the IBP, we don't recover the patient. So I had one case with the ECMO, but actually the patient collapsed. So the patient transferred from the Mekong River Delta to Charai Hospital. He's about 36 years of age. So they sent to the Charai doctor to put the ECMO first because the patient is collapsing, nothing more. So after stabilize the patient, so for around more than 12 hours, so I put the patient to the cath lab and then to do the revascularize for the patient, and the patient recovered quite well. Actually, after the hypoxia improved, and then we revascularize for the patient, and that's very fantastic case for me. And he discharged after just about 7 days from the collapsing. That is fantastic case. So, but I don't want to promote the ECMO, but in this situation, the IBP is not effective anymore. So we have to think about the ECMO. We don't have the impeller. That's my experience about the ECMO. But we have to worry about left wall. As Dr. Bento mentioned about, we have prepared the left wall vessel because the complication of the ECMO is quite terrible. So that the lower limb is the suffer one. That they pay attention for that. Otherwise, we have to lose the lower limb after about 1 week or a couple of days if we don't care about that. Thank you.
Yeah,
So
I think that's very true. You know, my experience with you when we've been together at Chore is that you guys do incredible work. But it is so difficult to manage these ECMO patients afterwards. And if they have a vascular complication, they're going to die. And so, you know, you have to be facile with antegrade perfusion catheters, you know, how to, you know, get blood flow to the distal limb. And then you need to be close with the surgeons, you know, repairing the leg or fasciotomies, keeping the leg going, you know, because that is the major complication that, you know, the person's heart will recover. And if you've gotten to them fast enough, their brain is hopefully okay. But it's when the leg gets bad, then everything just goes to crazy.
So I have one question for Dr. Pinto and also the panelists here. Before the EBC man trial, everybody eager about the DK cross for the left-man disease. We do 2 stents with DK cross, but now we have the EBC man trial. They show the result. I think it's not so different between the 2 groups. So is it? I don't know that after the EBC man trial, what do you do in the clinical practice every day? What do you do? Just provisional or DK cross for the case? So thank you, Dr. Pinto.
Yeah, I'm very mindful of the idea that the provisional approach is preferred. In general, I like that approach, particularly for the left main, for the LAD diagonal or circumflex OM, PDA, PL. But when it comes to the left main, I'm unwilling to leave severe disease behind in the circumflex. I understand that you may want to leave it, but the side branch is the vulnerable portion of the bifurcation, and in this case, the circumflex. And if it's a sizable vessel that supplies a lot of LV myocardium, very often the circumflex doesn't, then I won't worry about it. But if it supplies a lot of LV myocardium, that person is going to come back with angina if there's a lot of disease. Now, if you don't treat them, you know, and then let them live with the angina, that's okay, I guess. But I believe we get a good result using intracoronary imaging with DK crush. And to some extent, my second strategy is if it's a T, I'll use a tap technique. But to me, you know, I have had, you know, I'm compelled by what they're able to accomplish in Nanjing, and I've really, you know, tried very hard to replicate their technique. And I think it is I try to do a good job in the left main also with imaging, as I've learned from Dr. Xiaolang. So, you know, people say that, oh, only the Chinese can get as good DK crush results, and all of us should be doing provisional approach, and culotte is just as good. You know, I find it easier to do DK crush than culotte, and I don't know. I don't think that it's that complicated. I don't know why everybody makes a big deal. I think, and the best treatment so far in interventional cardiology for restenosis is a drug-eluting stent. So I don't know why you would balloon an artery and then not stent it if it has a lot of disease. So you know, to me, that's how we create restenosis. So to me, I wouldn't balloon a circumflex and just leave it alone. I do want to mention that in some cases, I use pressure wire, FFR, resting index, IFR, to define whether there is a flow limiting stenosis or not in the side branch. But remember, there may not be a flow limiting stenosis by physiology, but if there's a lot of disease and burden and plaque by imaging, that disease is going to progress, and the person may not have angina now, but they may need repeat revascularization later. So I use, particularly in the diagonal and OMs and posterolateral branches or PDA, I use physiology to determine, do I really have to do bifurcation, stent, and I'll back into TAP. But when it comes to the left main, I feel like the person should get bifurcation stenting if it's a sizable side branch in the circumflex. But what do you think? What have you changed? What am I wrong? What do you do?
I have to say that I agree with you, Duan. I think that we have a big so I'm not comfortable to just leave it alone and then do a stent from left main, just a left main stent from LED. Because if, let's see, if we choose a provisional stenting from the very beginning, then the option of DK crush is not anymore. So we want to switch, then only culotte or TAP can be done after that. So why don't we just choose DK crush from the very beginning and then make it easy? I agree that a DK crush is not a very, very complex, very complicated technique that we cannot and only the China can do. Yes, the Vietnamese can do, Americans can do, and think everybody who willing to have it done in your practice, you will do.
Okay.
Yeah, you just have to try. You have to learn and try. And you know, one thing that I have changed a little bit is when I can, I know that this ostium of the circumflex is what's vulnerable. So I try to treat the LAD as the side branch in the DK crush. And that way the stent, the main stent is going from the left main into the circumflex. And the side branch is the ostium of the left main, of the LAD. And that's because if there's restenosis, the person can get a lima. Or I can restent or all that sort of thing. Or if the person gets restenosis and it's the circumflex, then it's like, oh, let's stent it again. We're not going to send them for a vein graft, or let's stent it again. And it's the failure mode is, I think, less advantageous for the circumflex than if there's a fail in the LAD. The person hopefully can still get a lima. As maybe, you know, down the road, I don't like to send people for surgery, but that's my kind of reasoning of why in the DK, I'll stent the LAD and really get a perfect result. And then I go from left main into the circumflex. That's kind of a little change that I've made in the last couple of years.
Yes, I think that's a great idea as well, because we have to prepare the landing zone for the surgeon as well. In case of we have to send a patient for outcat or something like that.
Yeah. And if the circumflex is fine, then maybe they just need isolated lima. You know, you still have options, right?
Okay, thank you.
I had another question. It's okay. Is the time is okay for one more question? According to the classification of Professor Ho Thương Dung with the phenotype classification, so can we call that it is a 3D classification or not?
Can you repeat again? Because a little bit noise.
Yes. I love the phenotype classification, and then as I usually mention about the bifurcation or trifurcation in my presentation before that. So the intersection in Dallas is quite different in Ho Chi Minh City. Intersection from San Francisco is quite different in Washington, D.C. So that's in my opinion that the bifurcation in LabMan is totally different with the bifurcation in LED diagonal. That the 3D classification. Is this your classification is the 3D classification or not? Thank you.
You talk about the sequential bifurcation.
Yes, that sequential or trifurcation or the 3D. Yeah.
The first, my remarks about complex bifurcation, the complexity of bifurcation PCI depend not only on the anatomy of bifurcation, but also depend on whole coronary artery tree. It means triple vessel disease. It means very stenosis, critical stenosis lesion nearby, or
yes,
some
the whole scenario.
In
the whole scenario, yeah.
Yeah, and the sequential tandem bifurcation, it means the two bifurcation tandem, but it near it will affect, but it very far not affect. Yeah, so this is my recognition. My remarks. Yeah, I think.
You know what I'll say though, there's one place where the intersections look very similar to me, and I always get lost, and that's Ben Thai Market. So whenever I'm in Ho Chi Minh City and I go to Ben Thai Market, I get lost because all of the intersections in the market look the same to me.
Okay. Thank you for your remark, your comment. And by now, we not the time. We will move to the next presentation. So we don't have a Dr. Michael Gibson now. So I introduce the next presentation. I would like to invite Dr. Yuan Pinto with the topic severe distal left man and acute and with the topic now the next presentation of the presentation. I'm sorry, the next presentation of Dr. Sandeep Nathan with the complex and bifurcation PCI essential technique for the chip operator. The technician, can you open the video of Dr. Sandeep Nathan? Technician.
Hình như là tới Dr. Pinto á thầy coi
Pinto hả?
Dạ thầy coi lại cái chương trình chút.
I can do mine if Sandeep is not here yet.
Oh yes, sorry, Dr. Pinto. I'm very sorry. The next presentation, Dr.
Tới Ngô Minh Hùng chứ, Ngô Minh Hùng chứ thầy.
Không, bài Việt Nam xong rồi tới bài của Mỹ chứ. The next presentation of Dr. Yuan Pinto. The topic is how not to do bifurcation procedure. Can report, please, Dr. Yuan Pinto.
Yeah,
I cannot hear you, Dr. Pinto.
Can you guys hear me?
Yeah.
We can hear.
Okay, it's okay.
Clearly.
Okay, hold on. I'm getting problems with Zoom. Okay, maybe.
So your voice is not good. So good. It's interruption. So please check.
I'm back. Is it working again? Okay, hold on. How's that? Can you hear me?
Yeah, clearly.
Okay. So I wanted to show a case where, I think there's a lot of room for improvement. Very often we show the success, but I would love also for you to interrupt me with questions as we go through, and there'll be a couple of learning points. Let's see, it's not advancing here. Okay, so we're going to review bifurcation stenting technique, interpretation of IVUS and OCT, and ways to correct inadequate stenting technique. This was a 74-year-old woman with chest pain and an abnormal stress test with anterior ischemia. She was found to have disease in her LAD involving the left main, and she had an occluded right coronary artery with left to right collaterals. Angiography was performed at an outside hospital, and based on the findings, the operator there decided to bring his case to our hospital because he believed that it required advanced equipment and techniques. So this is the angiography. And what do you guys think about this lesion now in the proximal LAD? There's some diagonal disease and mid-vessel LAD disease. You can see there's already a stent in the circumflex, and there's collaterals to the right coronary artery. The vessel was, I guess, thought to be somewhat calcified. So you can see here is the orbital atherectomy being done over the Viper wire. And you can see balloon angioplasty is then performed. And a stent is placed, and IVUS images, which I'll show you, had already been obtained. But in this case, the stent was thought to be too short, so it was removed, and a new stent was put in with the idea that 2 stents would be required. That was a 38mm stent and was not, that was the longest at that time that we had in the United States. And so a first stent was deployed, which you can see here. And then a stent was deployed into this diagonal branch with a portion you can see there sticking out into the left main. So you can make out the stent sticking out into the left main, and then there's another stent on that alongside of it. So what do you guys think of this strategy for approaching this bifurcation? So a balloon is inflated after deployment of a stent in the LAD there. I think you saw that being positioned there. That's the stent being positioned alongside the diagonal stent. And then there's post-dilation of the LAD stent. And then without removing the wire, the diagonal stent was post-dilated. So what do you think of that? Dr. Ho, Dr. Nyo, Dr. Nguyen, Dr. Vu?
Yeah, I think so. Your technique exactly, or which exactly the technique you perform to stand?
So I have to say it wasn't me, and to me, I don't know what the technique is. I think what you see are 2 stents side by side, one another, sticking out into the left main. It's basically non-simultaneous kissing stents, I think.
Yeah, I think this is the complex bifurcation because the important localization is proximal LD, and a reason involved both LD and diagonal. And in this in this view, look like you use V-stent simultaneous and V-stent. It means the stents in the diagonal and the stent in the LD have a touch of the ostium of diagonal. Yes or no?
Yeah.
Yeah.
Yeah. So I think it's kind of V-stent or simultaneous kissing stent. I think the stents are into the left main, so it's not truly a V-stent. I think it's closer to SKS, but they were not deployed at the same time. You know, and here's post dilation, and you can see that the stents are actually sticking out into the left main, and this post dilation is actually inside of the stents. There's, you know, not the proximal part has been, you know, dilated.
Mm-hmm.
And this is what it looks like angiographically.
Yeah.
And then that's the final angiogram here. Now, the operators had done IVUS. This is the IVUS run after the stent. You can see up here, I selected some frames. This is the stent. It seems underexpanded here. There's some calcium, but not a whole lot of calcium. It's underexpanded here. And just at the diagonal branch, it's also, I think, underexpanded. And this is the left main. And then I think you can make out that there's a stent here and a stent here in the left main. So I think you're right, Dr. Ho, that it's two stents in the left main, double barrel, you know.
Okay, Dr. Wu, you are expert of IVUS. You do analysis and your opinion about this image of IVUS.
So thank you. As Dr. Pinto say about the IVUS finding, I think the LED stent is underexpanded a little bit, and the second picture, in the middle picture, we see maybe from 9 o'clock to 12 o'clock, the stent not well opposition to the vessel, and in the left hand side, the picture in the bottom, in the left hand side, we see this is bifurcation, and we see the one layer of stent from 7 o'clock to 11 o'clock, but another side we cannot see any stent strut here. I don't know what happened here, but I worry about the stent position here. And of course, in the biggest picture, in the left main, we see two, I think two stent, SKS stent like this. We see the first one, the biggest, the bigger stent in the left hand side, and the second one in the right hand side, two stent. Yeah. So it's very interesting. What to do next for this patient? Just leave it alone, or we have to do something for this lesion. So I wonder. I don't know what to do next for this kind of IVUS result.
Well, you know, Dr. Vu, the operators did this IVUS, but didn't do anything else. I don't know that they recognized the underexpansion or that the two stents were placed like this. And I think that's one of the teaching points, is that doing IVUS or doing things, and if you don't know how to interpret the images, doesn't help the procedure or the patient. So, you know, unless you can interpret what you're seeing and do something about it, it's not, you know, all of the studies, you know, that show, you know, even a mortality benefit associated with imaging and IVUS, is the understanding is that people know how to interpret the IVUS. And in this case, you know, the operators did the IVUS, but I don't know that they recognized what they were seeing.
Yeah. So what do you think, what we do next? Just medical treatment, we do something more? Please give us some comment from the panelists, please. Dr. Huy and Dr. Hùng.
Dr. Huy, Dr. Hùng. And in my experience, when I have the lesion in the ostium of bifurcation, sometimes we use the two stent. I remember Dr. Hồng in the last meeting I have with you. You have a one case look like that. In the lesion in the ostium of the side branch or in the main branch. But when we deploy the stent, we always do the simultaneous kissing, because if we do not do simultaneous kissing, the stent very easy to carina blood ship or clot ship. But if you don't you do simultaneous kissing with the high pressure, it's okay. And in this case, if we don't do the simultaneous kissing, when you do in the LED and in the diagonal, the canina will go change the direction. After we deploy in the diagonal, the ostium of diagonal good, but the stand in the LED not good under expansion. If you do high pressure in the stand in the LED, the stand in the LED good, but the ostium of the diagonal not good under expansion. I think so. How about Dr. Hồng?
Yes, totally agree with Professor Yong that actually it's quite difficult to fix to repair the lesion like this again. But actually we have to do something for that. Otherwise we have to lose the patient because we have to stent thrombosis. So I think that in this situation we have to analyze the first picture again and see that the under expansion quite clearly. So we have to rewire again, and then we do the simultaneously kissing with the high pressure at the same time with the suitable exactly the diameter of the vessel in order to get well opposed of the stent to the wall. Thank you.
Okay, so, like I said, I don't know that the operators here knew what bifurcation stenting technique they were doing, and I'm relatively certain they didn't interpret the IVUS correctly and they discharged the patient. And 6 months later, he has rest pain and non-ST segment elevation MI, and this is when I meet the patient. So what do you think now?
So I think the LED ostium, we have the tight lesion in the LED ostium. So this is the reason why the patient has a symptom and come back to the hospital.
Yeah, agree. And I think we now realize that this, needs to be treated more effectively, more definitively. So what I decided to do was wire the LAD, trying not to involve any struts of the diagonal. And so you see wiring here, and then there's a microcatheter that I used, Turnpike LP, and I advanced the microcatheter just to be sure it's moving freely, that I'm not engaging a strut of the diagonal. And here's that view. And you can see very tight lesion in the ostium of this LAD stent. And there's actually quite a bit of disease distal to the stent. Maybe it's a little underfilled. It was a lot bigger on the previous angiogram. But I decided to treat the mid LAD and ballooned open the proximal vessel, and then stented from the proximal LAD into the left main and optimized that with POT. And then rescued, rewired the diagonal, and then did kissing and balloon inflation. So really kind of turning it into more of a crush technique, so that the diagonal stent was crushed. The left main was open widely now, and the proximal LAD was widely expanded. And so you can see the result angiographically there. There's a funny looking appearance here proximally. Yeah. So we post-dilated some more, and then this is what it looked like angiographically. And then we performed OCT. And you can see here, these white dots are the stent apposition is good. As we're moving through. Not a lot of disease in this portion of the vessel. That was a side branch coming through, but all the stent looks very well opposed. Now we're coming to the area of the proximal LAD where it was somewhat underexpanded, as you saw. It's a little smaller there, but well opposed. And then we've come into the left main, and that was a little underexpanded there. We did post-dilate then based on that finding. Here, see that there? It's a little underexpanded in the left main. So then we did further post-dilation, and you can see that it was well opposed in the left main. So I think, you know, there are a number of lessons, I think, from this case. We need to be meticulous about bifurcation stenting technique, and we shouldn't be enamored with new technology just to use new technology like orbital atherectomy or microcatheters. You still need to know the basics of good technique, as we talked about, the DK crush, the culotte, and tap. And as I mentioned, intravascular imaging helps nobody if the operator does not utilize it to interpret the data effectively. I mentioned earlier, a stent was put in and it was found to be too short, so it was taken out. Well, IVUS was performed. You can measure the length of the vessel and know exactly what size stent and what length you need. You don't need to make that mistake of having a stent that's too short. And then afterwards, you have to recognize whether the stent is expanded properly and whether, you know, the morphology of the stent is something that you are happy with. But with that, I'll stop and take any questions or comments.
So very excellent present case for we choose the intravascular imaging for the guidance to optimal PCI. May I ask you a question about the OCT, the result of the OCT you perform after you correct before you correct the lesion? The second time.
I didn't do OCT pre-repair because the lesion was so tight. I didn't think I'd be able to deliver it or opacify the vessel. And I wanted to do OCT rather than IVUS. So in that case, I wanted to treat the vessel first. And then at that point, after I pre-dilated, I decided that I would just continue with the procedure rather than to stop to image the OCT. I used it for optimization of the sizing of the LAD in the left main.
Yeah, yes, I understand. Because if we have the situation of a stent failure, such as your case, if we can do the intravascular imaging by PCI, we can understand clearly the mechanism of stent failure. Look like under expansion stent or some restenosis, some thrombus due to antiplatelet refractory. But the
I knew from the IVUS, the IVUS of the last procedure, that it was underexpanded and somewhat calcified. I also knew that I was going to balloon it, and the presentation was non-STEMI. So if there was thrombus, it was going to get ballooned, and that was it. And if it was neointima, it would be strange in 6 months with the drug-eluting stent for it to be neointima but I already knew it was going to be some element of thrombus and under expansion because of the IVUS before.
Okay, thank you so much.
Dr. Pinto, I have one question. Because the second PCI, you do the wiring, right, to LED?
Yeah.
So because in this patient, we have two center. First one in the LED protrude a little bit to the left main, and second one from the diagonal protrude a little bit to the left main. So we have two layers of the stent. So I think you have very clever to be clever to do a wire exactly into the LED standing. So I keep please give us some tip and trick to do the wiring for the LED in this case.
Yeah. So I think the microcatheter helped. Working in that caudal view with enough LAO and enough caudal so that split between the LAD and the diagonal was visible. And then when I first started wiring, I coned in. So it was very, I had good X-ray view. And then it was, just luck. I think getting up there, I used, I think a workhorse wire, but then I advanced the microcatheter in just to be sure that I was not under a strut or, in and out of two struts between the diagonal and the LAD. So when that went very freely, I was happy. But I think it's not that much magic. I think it was luck. And it wasn't that much skill. I think any of you could do it. It's just a matter of trying and just, there's plenty of time and the person was stable. So, I just knew that was but you're right. That was the key part of the procedure, was making sure you're luminal. If I was not luminal or I wasn't sure, then I would have used imaging up front to make sure that the wire was not in and out of a strut.
Thank you.
So back to the first procedure was done by your colleague. So would you choose a longer stent for the proximal LED?
Yeah, I would have stented all the way into the left main, and I would have, done the diagonal either as a DK or, it's an angle, it's an acute angle. You could have done a culotte, I guess, but I would have done it as a DK, and then not tried to just be cute and be just like barely in the ostium of the LAD. I would have just said, look, we're going all the way back. We'll jail the circ, and after I've secured the diagonal, it'll be fine from the very beginning. But how would you have approached it?
I think I would do the same, just because if we do IVUS or OCT before procedure, then we would have an idea of how long we stand. And then I think maybe a longer stand for proximal LAD to left main will help. After that, the IVUS or OCT can give more idea about how is the ostium of left circumflex, and then we can go ahead after that.
Yeah, and one thing I would have done differently now than when I did this case is with the diffuse disease in the LAD, I probably would have done physiology and done FFR pullback, IFR pullback, and we have co-registration now too with the Volcano OmniWire. So I would have seen exactly where the pressure drop-off is in the diffuse disease and treated all of that, rather than, I had to put that mid-LAD stent in also because there was a lot of disease left behind, but I would have decided how long of a lesion to treat of all of that disease based on physiology.
So Dwayne, do you believe in the drug-coated balloon for the side branch in bifurcation treating?
I have to believe only what people tell me because we don't have it in the United States. We are only in trials right now. So we don't have it available. So I can learn from you because I've only heard about it.
Dr. Hong, any idea about drug-coated balloon for side branch treating in bifurcation?
Yes, that's good. That's good idea as well. Because in this situation, I think that 6 months already. This patient come back with 6 months with the symptoms. So I think that after discover that the stent not well posed, so I use the high pressure balloon first, and then maybe I use a coated balloon for the side branch as well.
I just didn't like the idea of the 2 stents in the left main like this. You know, I felt that that had to be corrected. So for me, that required a new stent from the LAD into the left main.
Pinto, Dr. Pinto,
Yes.
can you talk to us a little bit more about the turnpike family microcatheter?
Yeah.
Because we
So,
don't have here in Vietnam.
Yeah, so they're spin catheters. They're not push catheters. They've got a braid in them, and I think they're extremely valuable. They cross even times when a small balloon doesn't cross, and that's because the torsional force, just like rotational atherectomy, reduces the friction. There's a technique to utilizing it, of spinning it and slightly pushing with your left hand. It's easily learned, but it is my, then there's the Turnpike LP, low profile. It has a smaller outer diameter. That's the one I usually go with first. Our CTO operators, Dr. Ye and Dr. Tamez, they like Turnpike Spiral, which has on the tip a little bit of a core, so that it can kind of drill through almost like a tornus through sometimes diseased artery, calcified diseased arteries. So they're using a little more of the Turnpike Spiral. It has a kind of a wind on it. It kind of gets in there, digs in, and then you can spin it through. But for just regular work, I like the Turnpike LP. Now, I know that, I've been to your cath lab. I think you have to be mindful that a lot of spinning can fatigue the catheter. So, if you're going to reuse the catheter or something of that sort, first of all, the lumen can get build up a lot of stuff. Over the course of a case, I find sometimes it's difficult. And then also be mindful that after a lot of use, the catheter can fatigue. But I think if you're going to get one, I would do the Turnpike LP first, and then maybe the Turnpike Spiral.
Thank you.
Okay.
Dr. Vinto, I have one question for you. Can you share your opinion about the cutting balloon or core balloon in this situation? Because the orbital atherectomy not available in some countries, but the cutting balloon or scoreless balloons available. So some, especially in our country. So can you share your opinion about this? Thank you.
Yeah, even though we have orbital atherectomy and rotational atherectomy in our cath lab, we probably haven't used an orbital atherectomy catheter now in about a year. We use mostly rotablator for atherectomy. And I find that when I'm very comfortable with it. I've used it for 25 years. Most of the lesions, I don't find an advantage where I wish I had orbital atherectomy instead of rotablator. But very commonly, the opposite is true, that I prefer rotablator over orbital atherectomy. And that's my opinion, my kind of practice. And yes, I like to use the cutting balloon in general. I like to do it before a stent is placed to prepare the lesion. At times, I will do a high pressure cutting balloon inflation inside of a stent, but I don't think that the razors on the balloon do anything if there's a stent. Like, I don't know that it really can make it through and cut the vessel. So I don't really use it for in-stent restenosis or under-expanded stents. I don't think it works any better than a non-compliant balloon at high pressure.
Yes.
You know, one thing that we also don't have in the United States, but you guys might have, is the OPC balloon that you can take to 40 atmospheres. I have heard from my colleagues outside the United States that they prefer this balloon for high pressure post dilation, but we don't have it in the United States.
Okay, thank you so much for very excellent presentation of Dr. Duan Pinto. Demonstration for the guidance of intravascular imaging to be through the strategy of PCI or redo PCI. Thank you so much. By now we move to the next presentation of Dr. Ngô Minh Hùng with the topic severe distal abscess with acute angulation to a diffuse LED. How to conquer this situation? Okay, report, please, Dr. Ngô Minh Hùng.
Thank you very much for the introduction. Good morning, Vietnamese colleagues, and good evening, US colleagues. And I'm very happy to meet up my friend again, Dr. Pinto, and my master, Professor Thạch Nguyễn, and Dr. Gibson as well. So, significant left-man coronary artery disease, an indication for revascularization. Surgery is often considered in this set of the lesion, especially when the other main vessel disease coexists. PCI for this kind of lesion is definitely one of the more challenging procedures for the interventional cardiologist. And for treating this kind of lesion, several aspects need to be considered, as the previous presentation showed for us today. And they include the bifurcation anatomy, trifurcation anatomy of block layout or composition, and patient's clinical status as well. So this is a 51-year-old gentleman. His risk factor is a smoker, hypertension, and dyslipidemia, no COPD, and no peripheral vascular disease. But medical history and present illness, he had been suffering from the stable angina, CCS, class 3, and even on optimal medical treatment. Syntax score is 42, and syntax score 2 is 25.7, and FTX score is quite low. This is the EKG of the patient. This is normal sinus rhythm. You can see here that the quite optimal heart rate with the medical treatment, but the patient still had symptoms when he does the exercise, just the normal exercise, light exercise. And ejection fraction is quite still okay, 55% with the hypokinesia at the anterior wall and without any significant regurgitation of mitral or aortic valves. So this is the picture of the patient. You can see here that it's quite tight distal ligament at the bifurcation, and this is the ramus, and this is the distal ligament again, and it's a very tight atrium of the LED with the band between the ligament and the proximal LED not very clear because the 3D angulation that is here. So this is the timid angle, so we can show again that the diffuse disease of the proximal to mid and even to the proximal portion of distal LED as well. So this is the picture on the right side. This is a moderate lesion on the proximal to mid and distal RCA. So this is the syntax score. Syntax score 2 is 25.7%, and previous attempts were failed due to the Y could not cross the left-man LED lesion. So based on the evidence base, we have this syntax trial that with a low syntax score, so we can do the PCI for the patient with a quite acceptable result between the 5-part and PCI. Like this, so with the another randomized trial, like a five randomized trial like this. So we have the quite acceptable with the PCI, between PCI and bypass surgery. However, we have to some outcome, the bypass surgery better than the DES intervention with the DES like this. So with the bypass surgery, this favor for the bypass surgery if the patient come back with the symptom. So based on the evidence-based medicine, so bypass surgery is in general better than the percutaneous coronary intervention because this is the highest impact score. And in fact, the patient chose the PCI, even consulted the quite well by the good surgeon. And left-man PCI strategy is for this kind of situation is just the crossover stenting, and the interventional cardiologist as first thing that we should put the wire in, and then we do the ballooning, and then put the multiple stent for this situation. But however, it's how to do that is the point. And look at the some paper again, and it is the strategy in order to deal with the intervention for the left man. So with the wide angle between the direction of the left man and the LED, or we can say another word, we can say that the left man and the LED with the acute angle. So this is quite not easy for the interventional cardiologist, and it is unfavorable for the intervention. So the previous attempts were failed because the wire kept going to the ramus or to the circumflex. The guiding catheter is quite too deep or is not safe for the patient, and the guiding catheter is too proximal. It's not easy to control the tip of the wire as well, and the wire prolapsing into the smaller branches nearby due to the branches were straighter than the proximal LED, and they also use reverse wiring, but the wiring didn't work because the very tight atrium LED lesion and a huge angulation between the direction of the left main and the proximal LED. So this is the picture. You can see here that they use the previous attempts, they use the EBU guiding catheter, and I changed to the JL catheter 3.56 frame. The wire they're using is the run-through pilot PD2 MS, through the XT Gaia 1, 2, even the micro catheter, and use the double lumen catheter as well. However, the wire keeps prolapsing to the ramus like this, and this just the very close to the atrium of the diagonal of the LED like this. Make the U-turn and then go back. When we keep pushing, it prolapsing to the ramus or prolapsing to the circumflex. So I just stop here for a while in order to mention about the classification. Usually they a lot of classification they mention about the angulation between the main vessel and the cypress. Not they don't mention about the main vessel and the main branches. So according to definition 2 as well, they don't mention about this angulation adding it. So we have to pay attention on this. So see here again, this is the angulation between the left main and the LED. Or we can say another word, we can say that the direction of the left main and the LED. So another view, the wire cannot cross the lesion because it keeps going to the ramus like this. Here they change the position of the guiding, and the wire come here and then cannot make the U-turn. Come here and not make the U-turn and stuck here. at this point, very short point, but very acute. You can see it again. This is the filter XT wire, but filter XT wire cannot cross, it's stuck here, and it makes the U-turn stuck here. And if we put the guiding, we dip the guiding had a very severe lesion here, so very dangerous for the patient. So not easy to control the guiding, and also not easy to control the wire. So the patient, after that, the patient sent to the X-ray department in order to do the MS MSCT, and in order to see what's happening here. So actually, the left man is here, and a very acute pain here, and then the LED, but very tight at the distal and the distal left man and proximal LED. So what should we do next? Dr. Pinto, I can stop here for a while and ask you a question like this. Are you still there?
Yeah, I don't know. I think it was valiant effort. You know, I think I would try again with maybe a different microcatheter, different shape, maybe thinking about a different shape guiding catheter. But I think that was the best. That was fitting fine. I personally, think when I have these situations where I'm able to wire one of the branches, but I needed to very finely get an abnormal takeoff. I like the dual lumen catheters, the Suzuki catheter, or this predecessor was a twin pass torque, but the Suzuki is what we've been using now. And I think, I think that just with enough trying, you'll get it.
Yeah, thank you. Actually, I just a couple of minutes before I just asked you about the turnpike microcatheter, because I love that kind of microcatheter. They have the U-turn like this, but we don't have here. So
one other catheter that we use, I must say, I have maybe 50-50 success with the Supercross catheter, which has, a number of different bends on it.
Yeah.
But the 120, when you put the wire in, it comes out at about 90 degrees.
Yeah.
So I think that, with that angulation, maybe even a Supercross catheter.
Yeah, totally agree with that. But we don't have here. So actually, we explained to the patient again in order to see he changed his idea, the opinion or not, but he still keep on the doing the PCI for him. So the patient was sent to me. So
who can help? Do you use double lumen, the crusade?
Yes, they did. The previous operator already did that. The previous.
It's just really hard to understand the bifurcation here.
Yes. You see here the previous attempt already used the double lumen catheter and with a lot of wire, except the confluenza 3. Confluenza 3, the Gaia 3, they used up to Gaia 2nd and Gaia 1st, filter XT. PT
Gaia 3rd is dangerous, I think, because they
thought about that, but they failed because the wire kept going to these two big side branches here. So
I might go the opposite way. I might use, fielder. Not XT, but maybe fielder FC.
Yeah, actually the PT2MS and fielder FC is quite almost the same, and they use the PT2MS and the Pilot 50 as well. So quite the same with the fielder XT.
In my opinion, I think this case the most important point is that the entry point of the LED. So I think this is most important. And this is ambiguous, the LED oscillum. So I have one option that we can try the IVERS. For this case, we use wiring for the Ramos, and we try the IVERS, and we see the sum of the LED, and we can explain about why we very difficult to wiring LED. LED calcify or something like that. Maybe if calcify, we have to use a stiffer wire, or if LED not so awesome, not so calcified, we can try the softer wire for the patient safety.
Yes.
I think iVerse is a good choice in this patient.
Yes, agree with you, but you to be very brave. Otherwise, you dare not to do this kind of iVerse imaging because the very tight distal at the distal alignment because it's very large territory downstream. So if we do the ballooning here in order to do the iVerse, so quite scary because you can mix, you can make disappear the LED. So you cannot use the iVerse directly in order to see this because it's very tight here. It's quite scary in order to do the iVerse. But I asked the previous operator and they dare not to use iVerse because this kind of reason. So I also don't think about the iVerse because I think about the iVerse, but I'm scary about the occlusion of the left man during doing the iVerse. That's my opinion. So this is my turn. I use the also the six friend getting catheters here as I put here, but this time I use quite different. I use the very soft wire, feel the XT again and see how, but I come here and make the U-turn like this, but keep pushing the wire prolapsing. When we pushing the wire prolapsing to the remus here, and sometimes it prolapsing to the circumflex, not to the LED because the acute angle, very acute angle from left man to the LED. If we say that the direction of the left man, it means that from here to here, so the angle from here to here is about 120 degrees, something like that. So I think, yeah, this is the still picture. So the wire keep point here, but cannot make the right turn or U-turn. So we use this, make the U-turn, but keep pushing and prolapsing like this. Here's the reverse wiring. We make the U-turn and pull it back. It comes to the proximal LED. However, when we keep pulling, it's go out. It's not go into the LED. So we use the new technique. The technique is sometimes we use the interventionist. We use the balloon because they prolapse into the ramus. So we have to use the balloon in order to stop the prolapsing that. So we use the balloon 2O balloon for the side branch. So it's not very worried about the ischemia of this territory. So we use a 2O balloon as they put here, compliant balloon, and with the SUO. SUO is the why for the intervention for the CTO doing.
Yeah.
So yeah,
I mean, it's something like you're wiring a retrograde collateral.
Yeah,
you just need to
definitely like that. Because the SUO wire is the farther way to go. And we don't do anything, just pushing slowly, gently, and then going. However, when it pushing like this, it's going, but it's coiling here. So it's coiling here, and we have to, it's time to pull it back because we cannot keep pushing at this point of time. So you can see here, a very still picture here. When you're pushing here and it keep pushing, it prolapse to the circumflex in this point of time. So then at this point, we have to pull it back in order to stretch this portion of the wire. And then here how I do it. Very fast. I can't believe this is quite fast because it
amazing.
Yes, it's very fast because before that we think a lot of because keep directly wire, but we don't think about the reverse wiring with the balloon. So you see, very fast. When it keeps prolapsing, we have to stop in order to pull it back here. See? Okay. So from now on, we just finish the procedure. After the wire cross the band, and then we use the 5 micro catheters slowly advancing, and then we exchange with the workhorse wires, and then we finish the procedure. And this is the rest of the thing. I think I don't want to present because just ballooning and then put the two stand to the LED to the left man. And very lucky that the atrium of the circumflex is still patent, still open. and timid three flow for the remus and the circumflex as well. And this is the still picture in order to see again. And this is the IVERT finally in order to make sure that stand well posed and yeah. With very long IVERT, so just cut it up for the short one and you see the stand.
So Hong, I have to say that you have an amazing wiring. So can you, is there any difference with the tip of the sewer wire?
Yes, very good question about this, because I have to say that if you don't do the CTO revert like retrograde CTO wire, so you don't know about the sewer wire, because the sewer wire is the wire very soft, you have to be very gentle to take care of the wire tip, otherwise it's very easy to broken. So the outcome of the LEDs still patent. That's very good for the wiring for any wire, but the angulation is not favor for the rest of the wire, just favor for the sewer. So that's the reason why we have to use the sewer. Sewer is with just gentle pushing. Don't have to put too hard, just gently. Then the job done. Okay. So I have the animation for the anatomy like this, because I use the real picture and I draw again. And see here, this is the aneurysm, just aneurysm at the proximal at the carina, like this. So this is the ramus, or we can say that this is the early OMS also. Okay. So this is the circumflex, and this is the angle, very short angle. But the angle from here to here is quite acute, or we can say that from the direction here to here is about around 120 degrees. So just use the balloon to stop here and then go back from here to here is quite straight, very straight. So it's easy to go in. But how to make a U-turn is another technique, another skill. So I make the animation again. I put the wire. This is the run-through wire. And then I use a ballooning. This is the two-O balloon in order to stop the wire prolapsing. And then I use the two-O wire in order to go in and then go to the. Okay, so this is the total picture of the technique. This is the balloon-assisted wiring, revert wiring. So I just go to the conclusion that the left main coronary artery intervention with the single diffuse disease LED is a good candidate for the bypass surgery. However, in some situations, this is a big challenging for the interventionist when the patient turned out. And crossover strategy is always preferred if the reference a free or minor disease. However, it's easy said than done, especially when there is an acute angle between the left main and the proximal LED and contributed by straighter side branches around. Guiding catheter selecting and controlling should be paid special attention during performing the intervention for left main disease, and balloon assisted revert wiring technique is the good technique in this situation. Thank you very much for your attention.
Thank you so much. Very excellent about the tip and trick for wiring in this very difficult situation in the trifurcation and the very acute angle. And tip and trick with we block the unnecessary way, and we try to direct the tip of wire go to necessary way to do the PCI. Very excellent. I like to hear some comment and some experience from the panelists. Dr. Yuan Binto.
I think it's, it's an amazing case. I think, there's always this feeling when you're not able to wire a lesion, you get frustrated. You're worried that you can't complete the procedure. And I think staying confident and keeping an open mind to other possibilities. You saw that the other operators were actually going stronger with the wires. They were going Gaia third, you know, a Confianza, you know, and actually it was almost like you took a Zen approach, like collateral surfing, letting the wire do the work. And then I think it was a stroke of genius to have that blocking balloon there. And to then have it direct in that big curve. I mean, who wires like that? That's like, who tries to wire like that? I think it had to just go, and to have the confidence to do that is very impressive.
Okay, thank you, sir.
Thank you so much for your comment.
And I think today, young interventionists can learn many experience, many techniques in the presentation of Dr. Ngô Minh Hùng. But the young interventionist, you should keep in mind two sides of a coin, hai mặt của vấn đề. Because as you know, we must do the step by step, the simple step, and more complicated. And because the lesion is very critical stenosis lesion in the trifurcation, so we cannot use IVUS, we cannot use the balloon. So when we use the small balloon, it can get induce acute ischemic crisis. And if you don't choose suitable balloon, the side balloon, it can make some dissection. And with the wire go easy, such as the sure wire go easy, it's very easy to go to the dissect. So it needs to learn experience more and more and more. If the young interventionist, you encounter some difficult case, look like the case of expert Ngô Minh Hùng, you must do step by step. And I think the shape of the wire very important. In this case, you cannot bend the tip look like the normally. You must bend the shape of the tip sometimes abnormally, and it can go. I think in this case, very excellent tip experience and tip and trick. Maybe I like to hear some comment and some experience from another faculty. Maybe Dr. Professor Tong.
You know, I like to make one comment for the younger interventionalists is when you face something like this, when you're failing, there's a tendency to keep going and to try harder and to do more. And you might have seen someone do something. And I think you have to balance that against what becomes the next problem is small problems then accumulate, and you can then take bigger risks to fix a small problem. And then suddenly you have a big problem. And you start taking more and more risks as you get more and more frustrated and tired. And you have to recognize that that's happening and call for help. So either you stop the procedure if the person's stable, or if you call for somebody who's experienced, or just another set of person to come and look. It doesn't have to be more experienced person, but somebody who's fresh. And so if you're struggling, I think you have to recognize that you don't actually have to do it by yourself. And you might take more and more risk. And then suddenly you've turned a stable situation into a horrible situation. In this case, if you were to take aggressive wires and saying, you know, I'm just going to push through, and you dissected the left main and the LAD, now you're dead because you can't cross and the vessel is shut down and the person is sick. So it's better to say, stop, you know, I know my limitation, I'm failing. It's okay to fail. Let me call somebody to help me.
Thank you. Very excellent comment, excellent advice from Dr. Yuan Pinto. Maybe another faculty.
Yes. Thank
Yeah.
you, Dr. Hung. Thank you for your sharing case, a very interesting case with new techniques to the wide to the LED with the broadened angle left main LED. In the past, I have some case like this. So my successful case with microcatheter and the hardwire. And the second, we have the modified shape of the tip. The guide wire is very important. And I think we can try many times. So some case we have a lucky. I think that sometimes the wire couldn't pass in the LED, very difficult. So sometimes you can try many times. The wire go the ramus or the circumflex and modify the shape of the guide wire. So sometimes the guide wire can pass the RCO LED. So today you say the case, I think it's good for interventionists, your interventionists to have more experience in the future. Thank you so much.
Actually, this case is quite failure with the twice already, with the experienced operator, about 20 years of the experience. So we don't have to say it's quite easy, because we had to carefully see it again and why they fail. Otherwise, we had to repeat the procedure without any good result. That's the reason, because they have to know how to bend the wire already with the very U-turn wire. But when they go into the atrium of the LED and we keep pushing, it's collapsing. That's the point. So we cannot go with the very basic setting wire like this. And we have to use the wire surfing like Dr. Pinto mentioned about, because with that direction, easier, not this direction, because this direction is a very acute U-turn. We cannot make the right U-turn right away like this, but another direction is easier. So this my message to the audience, because we don't use like Dr. Pinto mentioned about that, we don't have to pay the very risky to in order to block the vessel and we make the complication. We have to stop the procedure with the stable patient and send the patient for another one. Thank you.
Okay, I agree with you. So by now it's the time we move on the next presentation. The next presentation of Dr. Sandeep Nathan with the complex and bifurcation PCI, essential technique for the chip operator. Please, the technician, you open the clip of Dr. Sandeep Nathan.
Nathan, it's a pleasure to be with you today. I thank the organizers of this meeting and the Vietnam Society of Cardiovascular Intervention for this opportunity to present. In the next 20 minutes, I will discuss essential techniques for the chip operator as it relates to complex and bifurcation PCI. I have the following disclosures to share with you. Okay, let's talk first about determinants of complexity in PCI. Many of the common elements are highlighted on this slide, including unprotected left main disease, bifurcation lesions, heavily calcified disease, and chronic total occlusions, patients with long segment disease, impaired ventricular function, and patients who are frail, advanced in age, or have other comorbidities. In 2020, the SCAI position statement on the performance of optimal PCI for complex CAD came out, and it categorized patients in terms of stable CAD without complexity, complex comorbidities or complex PCI, and patients with cardiogenic shock or arrest, and further divided it up into anatomic considerations, many of which I've already touched upon, equipment considerations, techniques and tools that you might want to use, and then finally patient comorbidities. So let's dive into bifurcation PCI. I'm going to restrict my comments really to left main bifurcation. I think that most of this is applicable to any sort of bifurcation so long as the side branch is big enough, but I think left mains representing the most important lesion subset for bifurcations deserves some attention. So the first consideration is stent strategy, single stent versus a double stent strategy. And among the double stent strategies, crush, culotte, T or V stenting tap stenting, simultaneous kissing stents, and DK crush may all be considered. It's important to recognize that using IVUS, the vast majority of left main bifurcations do involve the proximal LAD. And so consideration for preservation of the LAD and ensuring that there's no plaque shift or dissections that extend into that disease segment becomes of paramount importance. If you're choosing a single stent strategy and have to bail out to provisional stenting, the area that you cross that stent into the side branch, most often the circumflex, should help determine what type of technique that you use. So for example, proximal strut crossing might take you towards culotte stenting or T and protrusion stenting, whereas distal crossing may take you towards provisional stenting. And the important consideration is that there is complete coverage of the disease segment, that you don't leave a gap behind, and that the neocarina is now very well constructed and the stents are expanded and opposed. Why should you choose an intentional two-stent strategy and over provisional stenting? Well, there are multiple analyses that suggest that in complex left main disease, certainly, but even in simple left main disease or simple left main bifurcation disease, a two-stent strategy yields superior outcomes at long-term follow-up, and that's 1 year and beyond. And you can see here, both in the complex and in the simple left main bifurcation group, outcomes are improved, cardiac death and all-cause death are improved. So the two stent strategies that I find to be the most useful for these types of lesions is culotte stenting and DK crush. And so here's a pictorial representation from a beautiful article from a few years ago by Tanvir Rab and colleagues that lay out the individual steps for accomplishing culotte stenting. And certainly this can be modified for inverted culotte stenting as well. And so you can follow through step by step and complete the process. DK crush, as everyone I think recognizes, is a bit more labor intensive. There's more equipment changes and steps to follow, but in the end, it does yield a very nice technical result in the majority of cases. The DK Crush 5 study more or less validated this approach versus provisional stenting in unprotected left main bifurcations. Nearly 500 patients in all with Medina 111 and Medina 011 bifurcations are randomized to DK Crush stenting versus provisional stenting. And the primary endpoint of target lesion failure was significantly lower in patients who underwent DK crush stenting, and those curves diverged very early on and remained divergent for the duration of the follow-up period of 12 months. In simple lesions, there is a numerical benefit in favor of DK crush stenting, but in complex lesions, that's where the hazard ratio and the confidence intervals all support a superiority claim for these patients. And so the two-stent strategy, DK crush, laborious though it may be, was superior to a provisional stent strategy in this study. Are there other reasons to choose DK crush over culotte? Well, in this bench experiment, you can see that culotte stenting can result in a significant napkin ring restriction at either the side branch or the main branch ostium, depending on the technique, despite high pressure dilatation. So optimization, if you choose this technique, optimization with intravascular ultrasound or OCT is absolutely critical to avoid this constrained pattern that you see here on these sets of images. Still, culotte stenting, I think, has value and is a technique that should be familiar to you if you're going to attempt these types of lesions. And it can be done well with good long-term outcomes. This is a case example of a Medina 111 bifurcation, heavily calcified. You can't tell that here. This is a patient on dialysis for end-stage renal disease that we serially rotablated the diagonal, then the LAD, and then we performed inverted culotte stenting with final optimization at the time of the procedure using IVUS and very high pressure dilatations. And then 3 years later, when this patient was undergoing kidney transplant, beforehand, we brought him back and we studied him with optical coherence tomography, and you can see the 3D reconstruction with a very satisfactory final result 3 years later And this patient went on to have kidney transplant and did very well. Irrespective of the technique you use, however, proximal optimization technique is absolutely critical. You could see two sets of images. This is pre-potting and post-potting, and they look pretty much the same. They don't look a whole lot different. And this is after high pressure stent deployment from LAD into, from left main into LAD without dealing with the circ. So a relatively simple bifurcation lesion here. There was really no disease in the circ at all. So we chose not to do anything with that. The OCT tells a different story than the angiogram. This is pre-optimization. You can see there's quite a few malipose struts in the LAD as well as in the left main that we ironed out with 4.5 millimeter balloons. Here's a case example of DK crush stenting of a left main. This is an 86-year-old gentleman with an ejection fraction of 20 to 25%, left main bifurcation disease, as well as mid-LAD disease, as well as circumflex disease, although it's known that this OM territory is largely infarcted from before. This is a patient who had sustained a VF arrest. He was referred for PCI after he was declined for CABG. So we do have quite a bit of disease here, although big vessels to work with. And you can see that in these different views, the left main is quite diseased. So we supported this gentleman with an Impella CP because he had arrested before, because he had a 20% ejection fraction. We did the mid-LAD first. We wired the left main into the circumflex, dilated both the LAD ostium as well as the circumflex ostium. You can see a 3.0 by 12 DES side branch stent positioned at the circ ostium with about 2 to 3 millimeters of protrusion into the left main, deployed at 16, crushed. First kissing balloon inflation was performed after rewiring, then 3.5 by 22 DES from left main into LAD across the circumflex. And then we used the circ wire as a sepal wire to mark the left main ostium. He also had renal insufficiency, and so we were trying to minimize the amount of contrast that we were using. This stent was deployed at 18 atmospheres, as you can see here. Proximal optimization first with a 4.0 NC balloon at 18 atmospheres. Second side branch recrossing with a workhorse wire, knuckled into the LAD, withdrawn, rewired, and then the kissing balloon inflation was performed. And then final IVUS images, as you can see here. So crush and 2 kisses, and this is the finished result. And he actually did really well despite his advanced age, 86 years old, 20% ejection fraction. He was alive and event-free greater than 1 year later, and that's when I stopped following him and turned him back to his primary cardiologist. So that's a case example. And then the last thing I'd like to share with you is the value of imaging and adjunctive techniques in complex PCI. This is a network meta-analysis of angiographically guided PCI versus imaging guided PCI, either using IVUS or OCT/OFDI. And what you find is that there is clear benefit of using imaging guidance in PCI, whether it's simple or complex. This is inclusive of nearly 18,000 patients, and there was no real difference between OCT versus IVUS. Obviously, the advantage of IVUS is that it's available more freely, it's familiar to everyone, and doesn't use contrast to acquire those images. So whatever you use, that's up to you, but use something if you're performing complex PCI. I think everyone is familiar with the ULTIMATE trial that was presented and published a few years ago, randomizing patients to IVUS guidance versus angiographic guidance. In that study, there were 3 criteria that they primarily focused on: IVUS-derived MLA with greater than 5 in the stented segment, or 90% of the distal reference lumen CSA, plaque burden at the 5 millimeter border zones of less than 50%, and no edge dissection involving the media with a length greater than 3 millimeters. And in all comers, target vessel failure at 12 months was significantly lower with IVUS-guided PCI versus angiographically guided PCI. And that was particularly true in patients who had optimal PCI using those IVUS criteria that I mentioned before versus suboptimal PCI. They didn't fulfill all 3 of those criteria. So Again, whatever you choose to use is up to you, but use something if you're performing complex PCI. And as it relates to left main stent expansion, there are some numbers to guide us. And this is a classic paper that really demonstrated the value of very specific numerical cutoffs. LAD, this is the rule of 5, 6, 7, 8. So a stented circumflex ostium should be a minimal luminal area of 5 millimeters. LAD ostium, minimal luminal area of 6. The polygon of confluence here, where the carina is shaped, is 7, and then the midshaft of the left main should be a minimal of 8 millimeters squared. And if you observe this, you see a pretty significant reduction in the rate of in-stent restenosis. The last thing I'd like to mention here in the few minutes that I have left is use of adjunctive tools for complex PCI. Again, from the position statement from 2020, use intravascular imaging first if there's moderate to severe coronary calcium or inadequate balloon expansion, and consider really characterizing this lesion fully before deciding what tool to use, whether it's mechanical atherectomy, laser atherectomy, or lithoplasty, and use that along with image guidance to get you the stenting success. Rotablator, I think, is the most familiar tool the world over. There are yet many countries in the world that don't have access to Rotablator, and I'm certainly sensitive to that issue, but it is an invaluable tool for complex and calcific CAD. This is the RotaPro system and all of the burrs that are available and the minimum guide diameters that are recommended. Generally speaking, 1.5 and 1.75 get the most usage in our lab. Less often 1.25, rarely the 2.0 and larger burrs, but they're all pretty useful for calcific coronary disease, particularly if you want leading edge ablation. If the lesion is so tight that you don't think you're going to get a rotablator, is probably worthwhile. The Diamondback 360 orbital atherectomy system produced by CSI is also a very useful tool. This is a 1.25 millimeter crown. On the bench, it gives you a diameter at 120,000 RPM that's almost 1.75 millimeters. So you do get quite a bit of debulking, but if you notice the shape of the crown, the ablative surface is on the side. The leading surface does not have any ablative material, does not contain the diamond microparticles. And so for very difficult to cross lesions, this may not be the best tool, but it does give you quite a bit of ablation. And I think used appropriately, a relatively low rate of complications. I prefer this if there are sharp angulations, for example, a sharp angle into a circumflex that needs to be ablated, retroflex, circumflex, and so forth. And so this is also an extremely useful tool. And then laser for fibrocalcific coronary disease and also for thrombus management. And some of these are off-label uses for laser, but laser gets a lot of usage in our lab. A CTO case here that required contrast lasing to finish up. And you can also see a bench experiment here of what thrombus looks like when it's being lased with a 1.4 millimeter laser fiber. So lots of potential applications, including total occlusions, vein grafts, aortoosteal lesions, in conjunction with rotablator, so razor, as well as thrombus management. And then finally, we have intravascular lithotripsy or shockwave IVL, which is an array of mini lithotripters, very similar to what's used for renal calculi, kidney stones, within a semi-compliant balloon that's inflated to 2, 3, 4 atmospheres. And then the lithotripters generate intravascular shock waves, basically using ultrasound energy that are very short duration, but generate a peak positive pressure of nearly 50 atmospheres. That's capable of fracturing intimal and medial calcium without damaging the vessel too much. We've used this in the coronary, we've used this in the legs, we've used this for TAVR cases and also for subclavian stenoses with or without a grafted internal mammary artery. So really a very useful tool. So the key takeaway points then are coronary anatomy, patient comorbidities, and equipment needs determine the complexity of a PCI in large part. In bifurcation PCI, particularly left main, the distribution and severity of disease, the size of the side branch, and the presence of calcification in the bifurcation angle should help guide the choice of bifurcation technique. I've shared with you some data that I'm sure you're already somewhat familiar with on the intentional use of a two-stent strategy, which seems to be associated with more favorable outcomes rather than provisional side branch bailout. DK crush may be a bit more labor intensive, but it may be the preferred approach in experienced hands and supported ideally by intravascular imaging, recognizing that DK crush 5 used IVUS in only about 50% of cases. And then finally, use of intravascular imaging in adjunctive lesion preparation techniques and tools, including cutting balloons, atherectomy, IVL, etc., should be familiar to operators that are engaged in complex PCI. I'll stop there. Thank you again for this opportunity.
Professor Tong.
Thank you for your excellent presentation. So in your presentation shows many techniques and many information about PCI, especially in the complex PCI. So I would like to invite to some panelists give opinion and so comment. Dr. Ngô Minh Hùng.
Thank you. Actually, the very excellent presentation from Dr. Deep Nathan to the meeting today. So I think that's quite excellent knowledge that we need to know, and of course some device that we don't have here, like impeller, or we don't have the IVL, intravascular lithotripsy. And I favor the two-stent technique for the complex procedure, like the procedure need two stents, so we have to start with two stents at the beginning. It's safe for the patient. Thank you.
And another comment from panelists.
And yeah. Think about the EBC main result.
Yeah, so you know, I mean, I think that all of these trials really have to be put into the context of the operators that are performing them. So anything that comes out of any of the bifurcation clubs, whether it's, you know, Japanese, European, American, these are performed by master operators. And I think that the challenge is always to take those results and say, is this replicable in your lab with your expertise, with your equipment? I will also say that when it comes to bifurcations, we all perform bifurcations in our institution. And I don't know that that's always the best thing, in the sense that the volume gets divided in so many different ways. I think that as with TAVR, as with MitraClip, just a limited number of people should actually be performing complex PCI, ready to spend, you know, the 2, 3, 4 hours that it may take to actually get this right, rather than, you know, cruising through this and saying, well, it looks pretty good, you know, and move on to my next outpatient case. And so, you know, I think that all of these techniques are great, but practice makes perfect, and dedication to actually getting it right, and with a heavy focus on imaging. And I say that because imaging is available the world over, but it's not used all that often, even in the United States. So imaging is a sub 10% phenomenon in the United States for complex PCI, unfortunately, for all PCIs, unfortunately. I would turn this back to the panelists and ask, what do you think of the trial results in general? And is it generalizable to the practice in Vietnam, in other parts of Asia? What do you think?
You asking about the EBC man trial?
Yes, and you know, the trials in general. I mean, we put
yes.
5 up on a pedestal and say this is sort of the end all be all, but then you've got to be able to actually replicate what they did in that study.
I think that's okay. It's easy to apply in Vietnam, but with the decay crush are quite laborious for the operator as well. And with the culotte, I think less work than the decay crush. Do you think so?
In my opinion, very nice to see you again, Dr. Salim Nathan.
Thank you.
Yeah. In my opinion, the simple thing, we use the simple way, simple method to solve. The difficult or complex thing, we use the complex way, a complex method to manage. Of course, very easy. And I have a perform decay crush for a long time, and I like decay crush so much. But I give you one question. What the thing between the simple and complex, the thing between the simple and difficult thing? And young interventionists asked me about, in this situation, we use the provisional stenting side branch technique or we use the decay crush technique. And I think very difficult to answer. If I give advice to him, we use provisional stenting side branch technique. And so if nothing happens, it's okay. If something happens, to change from the provisional stenting technique with already one stent not right in here, the young interventionist change to two stent technique, but he doesn't have experience. I think not good. So in my opinion, if in the situation between the simple and complex, you should do two stent technique to learn the technique, to learn the experience. It's my. How about you, Dr. Sandeep Nathan?
I'm glad you said that. I agree with that. I think that you have to have all of these techniques under your belt. I think EBC Maine gives us the the data to stand on to say that sometimes a simpler technique is okay. It was a neutral trial. There have been editorials about how this is practice changing in the same way DK Crush 5 was practice changing when it came out as well. I think we have to sort of take a step back and say, what were the lesions that were actually treated? Can you compare between these two studies and say they were recruiting exactly the same type of patient? I purposely left out, in the interest of brevity, I left out a case that from my presentation that was actually very educational to me. It was a STEMI case, a primary PCI case that very quickly escalated into a left main culotte case. Heavy calcific disease in the left main bifurcation, and we were trying to fix the circumflex with a CTO-RCA and the left main shutdown. And the only way we could actually get through that case and save this guy and get off the table was by very quickly going to ad hoc left main culotte stenting. And so for the young operators, you have to have those techniques under your belt. And I'll echo something that my friend Dwayne Pinto said earlier. It's always good to get a second set of eyes on this and say, tell me, this is what I'm going to do. Tell me why I'm wrong. Tell me what are the flaws in my judgment here. And I do this. I've been doing this, for quite a while, and I still do that. Whether it's an older partner or a junior partner, I say, I just want a second set of eyes on this. What am I missing here? This is what I'm planning on doing. I'm planning on rotoblading this. I'm planning on a mandatory two-step, two-stent technique, because I really think that if we lose control of that side branch, we're not going to get control again. It's going to be really challenging to, with the angulation and with the calcification. And I think that's where those kinds of conversations is where all of the, the alternatives to what you're planning on doing start to come out. I have had the good fortune of traveling to Vietnam, of course, and sharing ideas with many of my colleagues and friends there. I've also gone to Japan a number of times, and I'm always amazed at the amount of time that's spent in preparing for cases, before you actually get in there with a needle in your hand. And I think that, for these left main bifurcation cases or any bifurcation case, it's good to have that conversation up front before you just sort of get in there and try something and see if it works out.
Okay, thank you so much. You have one question from Dr. Ishim and Dr. Nguyễn Ngọc Quang. How to choose the right size and pressure for port POT?
How to choose the right side and pressure for proximal optimization. So
Yeah.
proximal optimization serves two very important purposes. One is to oppose the stent, and I showed you that OCT image of two images, 4.0 and 4.5 balloon inflations, and no difference in the angiogram, but huge difference in the OCT images in terms of strut apposition. The other really important component of this is to ensure that the side branch is opened up so that the cells are opened up maximally to facilitate delivery of a second stent into the side branch if you need to. Generally speaking, we'll size this with IVUS. Whatever stent we put in, we generally size it for the distal vessel to avoid distal dissections. And so that's IVUS sized if at all possible, either beforehand or after the stent goes in. And then the pot balloon is typically about 0.5, sometimes a millimeter bigger than the stent itself. When we're working in the left main, you do have a little bit of wiggle room. Touch wood, I have yet to rupture a left main into the aorta or dissect into the aorta by potting. I've managed to do that in other ways with rotoblator and with CSI, but I have yet to do that with POTS. So generally it's about 0.5 to about a millimeter above. I usually go to 16 to 20 atmospheres when I'm potting in the left main.
Dr. Sandeep Nathan, can I ask you a question about the ADQUIS? We know that the EBC man just coming out, and then we had a lot of the comparison between the Q-Lot stenting and the DK cross as well, but the old Q-Lot stenting. So what do you think about the mini Q-Lot technique? I love that kind of technique, and I think nowadays quite emerging technique for the two stent. What do you think about that?
I still like culotte stenting particularly in the LAD. I've gotten away from it post DK Crush 5. I've gotten away from it in the left main, but occasionally we'll use that if this wasn't a planned bifurcation. As I said in the STEMI case, we had no intention of doing anything with the left main and ended up doing the circumflex as well as the left main bifurcation and then working on the LAD as well. Working in the LAD, or if it's a particularly large circ OM bifurcation, I think it's, culotte is still a very good technique. The bench data that I showed you with the napkin ring, constriction, I think that can be overcome using open cell stents and high pressure dilatation. I have not had a huge issue with that. If you're going to nominal, if you're going to 12 atmospheres, yeah, you're going to have that. But, if you're prepared to go to high pressures and do, meticulous kissing, I think that's fine. I still like culotte a lot but mostly for trunk vessels as opposed to left main.
So
I wonder what the practice is in Vietnam. Do you still do quite a bit of culotte in Vietnam?
I don't know other operator, but sometimes I do the culotte. But nowadays I do a lot of mini culotte, not the old culotte, because the old culotte overlap too much. Two layers too long. Yeah, a lot of metal. Yes. So just 1 or 2 dots is enough for the mini culotte. That's my technique nowadays. So I don't use the old culotte anymore.
Yeah, I agree. I mean, I've gotten away from running the stents all the way back so that overlapping in the main vessel, just to minimize the the amount of layers of metal. When that thing restenosis, if that thing restenosis, now you're already working with 2 layers of metal in the main vessel, and that 3rd layer of metal is probably the last move that you're going to play. So if you can avoid that, I think that's good.
Yeah, thank you.
Okay. Thank you very much for your share, your experience. So, any question or any comment for the panelists? If you don't have any comments, I would like to Professor Thạch Nguyễn will resend your presentation. Thank you.
Thank you, Dr. Sandeep Nathan.
Thank you so much for having me.
Thank you very much. And now it's my time. I have to talk quickly because it's late in the US and it is time for lunch in Vietnam. Oh my God, what happened? Share screen. Oh, so we're okay, right?
Yes.
Mọi người có thấy đó, ok. Vậy thì hồi nãy đó thì tất cả là mình đã nói tới cái vấn đề làm cái đặt cái bifurcation PCI. Thế thì cái câu hỏi lúc nào khi mà các bác sĩ mà làm khi mà can thiệp hỏi là làm như vậy đã đủ chưa, đã đúng chưa, thì cái câu hỏi lúc nào nó cũng nằm trong vấn đề đó. Thì bây giờ tôi đưa ra một cái, khi mà mình làm việc đó thì mình có một cái số câu hỏi. Ví dụ như cái hình này chẳng hạn, đây là một cái branch, đây là một cái lesion ở một cái side branch, thì tôi hỏi là tại sao cái lesion nó lại nằm ở đó, nó không nằm ở chỗ khác. Trong khi cái này hình này ngược lại, đó là cái lesion nó nằm ở lại bên branch, nó không nằm ở side branch. Tại sao như vậy? Và cái này hình này nó là nói rằng là cái lesion nó là nằm trước cái nó nằm là cái này là medina này là 100. Thì cái này nó là cái lesion này nằm phía trước của cái side branch. Mình phải hỏi là tại sao như vậy. Thế bây giờ đi vô ca đầu tiên. Thì cái ca đầu tiên thì thấy rằng là đây là cái lesion nằm ngay ở chỗ cái side branch. Side branch. Thì trong cái về fluid mechanics, thủy động học đó, thì nếu mà một cái dòng nước, cái dòng chảy nó đi bọc theo một cái đường cong, thì những cái dòng chảy mà phía trong đó nó sẽ bị recirculate, và như vậy nó là do là cái friction, cái ma sát của cái border, mà làm như vậy thì nó sẽ làm ra một cái turbulence ở ngay cái vùng mà gọi là cái recirculation đó, và cái vùng đó nằm ngay chỗ của cái mặt ngoài của side branch. Thì trong khi mình thì thường bên này mình dùng cái chữ là the turbulence happens at the outer curve of the side branch. Trong trường hợp như là đây là một cái left main, cái A2 là L lady và cái A3 là circumflex, thì lúc nào cái recirculation và turbulence nó nằm ở cái chỗ cái outer curve phía bên ngoài, và cái chỗ đó là cái lesion nó sẽ làm ra. Ví dụ cái trường hợp này chẳng hạn đó, khi mình thấy có những cái bệnh nhân rất lúc nào cũng thấy rằng là người ta có thể nhìn làm angiogram bảo là normal, không có gì sai hết, nhưng mà thực sự nếu mình nhìn vào cái góc của cái ostium của circumflex, lúc nào nó cũng có một cái chỗ, có một cái lesion nhỏ nhỏ đó, là do cho cái nguyên tắc kỳ trước đó là recirculation causing turbulence. Bây giờ qua trường hợp số 2, bây giờ cái trường hợp này đó là cái lesion nằm ngay ở bên branch, nó không nằm ở obtuse marginal. Thì hỏi tại sao như vậy? Thì khi mà tôi thấy là khi mà tôi dùng cái phương pháp mà dùng làm cái angiogram mà chờ cái dòng chảy, cái blood flow nó đi vào đó, thì mình sẽ thấy rằng là trong trường hợp này đó là cái dòng chảy chính, cái primary flow nó nằm ở từ LCX cho tới obtuse marginal. Thì mình thấy đây là cái A là nó cái bình thường, và đầy hết tất cả là full with contrast. Cái B đó là cái dòng máu nó màu trắng nó đi vào đó, thì thấy rằng là đây là vì là circumflex với OM nó là một cái đường thẳng. Thành ra vì vậy mà cái primary flow nó nằm đi được chỗ đó, và recirculation nó nằm ở bên cái main branch, và vì recirculation nằm ở main branch thì cái lesion nó sẽ nằm ở đó. Để qua trường hợp số 3, đây là cái trường hợp này. Thế thì tại sao lại cái lesion nó nằm ở proximal của cái PDA và cái PLB này? Thế thì tôi mới dùng trong cái fluid mechanics và thủy động học. Thì bây giờ đây là một cái thùng nước, và nó có một cái tube, và đằng cuối cùng nó là cái valve. Khi mà cái valve này dòng nước đang chảy một cách bình thường, nếu cái valve này đóng một cách đột ngột nó sức, thì làm cho cái dòng nước nó bị khựng lại. Và trong khi đó là cái dòng nước, cái phía gần nó vẫn chảy như thường, nó vẫn chảy xuống, nó khựng lại, và nó va chạm, nó làm một cái collision between cái dòng chảy phía trên và cái dòng nước ở dưới, nó bị khựng lại. Và khi mà nó bị va chạm như vậy nó tạo ra một cái chấn thương, injury, và từ injury đó tạo ra cái lesion. Và cái trường hợp này người ta dùng trong cái bên thủy động học, người ta dùng chữ là Waterhammer shock. Thế thì đây là cái trường hợp này, đây là nếu mình nhìn cái động mạch màu đỏ A1, và nếu mà mình nhìn theo kiểu cũ, tất nhiên là từ A1 sẽ đi xuống chẻ ra hai nhánh. Nhưng nếu bây giờ mình nhìn ngược lại, đây là hai cái dòng sông nhỏ, một cái dòng sông lớn và một cái dòng sông nhỏ, nó chập lại, nó thành ra một dòng sông lớn. Thì cái recirculation nằm ở chỗ nào? Nó nằm ngay cái chỗ mà cái chỗ mà của cái artery mình vừa mới thấy đó, nằm ngay cái chỗ đó. Thế thì bây giờ mình hỏi ngược lại rằng là cái trường hợp nếu như thế này thì làm sao mà chứng minh được rằng là cái dòng máu trong coronary artery nó chảy ngược lại? Tại khi mình học, tất cả mình học là đều học là dòng máu từ coronary artery chảy xuôi chứ. Nhưng mà khi mà nhìn trong cái flow, nhìn flow và đo cái flow của cái cách mà tôi đang làm đó, thì mình sẽ thấy rằng là cái dòng máu của coronary artery nó có thể chảy ngược lại khi mà bị khi mà during systole, tức là trong thời kỳ tâm thu. Và cái chuyện nó đã nói rồi, nhưng mà không có ai có thể chứng minh được bằng hình ảnh được hết, là vì không có cái cách để chứng minh thôi. Chứ còn về Doppler study thì có nói là có dòng máu coronary artery có chảy ngược lại trong thời kỳ tâm thu. Đó, thì bây giờ trong những cái hình tiếp theo này là ECDB, DEFGH, là cái hình này nó là liên tục và nó là 0.06 second per image. Lúc đầu là cái trong cái hình này màu đen là contrast, và màu trắng ở trong cái artery là máu đó, máu nó chạy xuống đó. Từ cái E này là máu đang đi xuống, và đi xuống tiếp thì nó đi qua chỗ cái PDA. Đây là trong thời tâm thương diastole. Nó đi xuống nữa thì mình thấy một cái dòng máu đi chảy xuống nữa. Đây là G, nhưng look at the H. Đây là systole, và cái dòng máu chảy ngược lại. Cái trường hợp này đó là tôi nói là đây là cái hình của tôi. Thế nhưng mà các bác sĩ khi mà về lại trong cái cath lab của mình và nhìn lại thật kỹ và đi từng frame by frame, 0.6 second per frame, thì thấy rằng là sẽ thấy được cái hình này. Nhất là cái trường hợp mà nếu bệnh nhân bị systolic hypertension, lúc bây giờ in systole, the ventricle contracts so strongly and cause retrograde flow in the coronary artery. Và đó nên, nhưng mà nó chỉ có retrograde một chút thôi, rồi sau đó nó bị cái dòng máu nó chạy anticate lại giống như hình này. Đó, thế thành ra mình thấy rằng là thì nói là hai chuyện, trong hồi nãy hai cái. Thứ nhất là nếu mà cái anticate flow chảy dòng xuôi thì cái separation and turbulence nằm ở bên cái side branch. Nếu mà chảy ngược lại, hai cái dòng sông nhỏ nó chập ngược lại đi vô một dòng sông lớn, thì cái chỗ mà nó bị recirculation nó nằm ở bên cạnh của cái nhánh lớn. Thế bây giờ đó thì mình thấy là cái hình số 1, đó là cái hình này là cái hình quan trọng nhất, và tôi rất là hãnh diện nhất trong cái khám phá này. Cái này là chưa có ai khan để nói ra cái này hết, mình rất là đặc biệt nếu mà trúng là một. Cái thứ hai là thì cái chuyện mình thấy là separation flow là do cái decrease speed ở cái border, đó là cái dòng máu nó chảy chậm lại. Thế thì đó là do cái nguyên chất này. Thế thì mình thấy rằng là nếu mà những cái calcified lesion hay là nó bị cọ sát nhiều quá, too much friction by calcified lesion, rất có sự xảy ra. Thế bây giờ đây cái hình số 3, rigid frame. Thế bây giờ cái hình này thì đây là cái ostium của circumflex. Thế tại sao cái chỗ này nó lại bị một cái lesion ở đây? Tại sao chỗ này nó là một cái rigid frame được? Thì trong khi mà mình làm angioplasty thì cái chỗ mà rất là không phải là rất là, nhưng mà dễ bị khó đẩy cái stent vào, đó là proximal segment of the circumflex. Proximal LED rất là dễ. Proximal right coronary, mid segment of right coronary artery rất là dễ. Nhưng mà cái chuyện mà khi mà đặt một cái stent và đi qua cái góc 90 độ này của cái left main and circumflex angle, là cái đó rất là khó. Không phải rất là khó, nhưng mà nếu mà không để ý là nó qua không được. Thì mình có cách của quan, có những cách, những cái tip, những trick để làm nó qua. Nhưng mà câu hỏi rằng là tại sao cái chỗ này nó là rigid, dù nó không bị cái calcify. Để xem cái hình tiếp. Đây là cái hình này là lý do mà tại sao cái proximal circumflex nó dễ bị cứng, cái vùng nó rất là khó đẩy cái stent qua, là vì nó nằm trong cái ống rãnh của cái giữa cái atrium và ventricle của tâm nhĩ và tâm thất. Cái chỗ đó nếu mà nó là một cái chỗ ghép đó, thì nó có rất nhiều cái chất xơ fibrotic lesion, fibrotic tissue để mà nối nó lại. Đây nhìn qua cái hình này, nhìn qua phía bên phải đó, thì cái chỗ mà cái atrioventricular groove là cái chỗ nối của tâm nhĩ và tâm thất. LA là tâm nhĩ, left atrium, LV là left ventricle, và của cái van mitral valve, cái van hai lá nó gắn vào đó, và cái EAT là cái mỡ, thì cái mũi tên màu trắng đó là cái circumflex đó. Thì như vậy, cái chỗ như vậy thì chắc chắn nó phải rất là cứng, rất là bền bỉ để mà giữ con tim chứ, không thôi thì nó bị rách ra sao đó. Cái chỗ đó để nói rằng là cái chỗ đó là rất là cứng. Vì vậy mà khi mà đi, thì nếu mà nó cứng như vậy thì cái chỗ đó nó không có đàn hồi, không có dán nữa, thì rất là dễ tạo ra những cái luồng máu mà nó bị turbulence, và turbulence thì nó làm ra cái lesion. Và như vậy mình thấy là trong tất cả một cái khám một cái làm cái angiogram, right corner artery có thể bình thường, left LAD có thể bình thường, nhưng mà lúc nào nhìn tới cái ostium của circumflex nó cũng có một cái eo hẹp lại một chút. Cái đó là thành ra cái chỗ đó là cái rigid frame để tạo ra cái lesion này đó, tạo ra turbulence. Thế bây giờ của cái số 3 thì bây giờ lúc ngày xưa mình đã học và nói rằng là cái angle từ cái left main qua LAD và circumflex, thì khi mình thấy như vậy, nếu mà theo về thủy động học thì tất nhiên là cái angle nó càng cái circumflex nó càng đi xa cái đường giữa của nó. If the circumflex is away from the center line, the farther it goes, the more turbulence it can be. Thành ra vì vậy mình thấy rằng là nếu mà nó càng ra nhiều như vậy thì rất là nhiều cái turbulence. Nhưng mà từ trước đến giờ chưa có chứng minh lần nào được rằng là nếu cái angle của circumflex và LAD và left main mà nó càng thành ra 90 độ thì là có nhiều cái turbulence. Chưa bao giờ chứng minh được chuyện đó. Và nếu mà nhiều turbulence thì rất là dễ để mà làm cái lesion ở đó và tạo ra cái eo hẹp ở đó. Thế thì bây giờ mình thấy rằng là từ cái câu đó nãy nói rằng là separation flow caused by large angle with the main center line. Thế thì bây giờ khi mình làm angioplasty thì cái góc của nó là 90 độ hay là 70 độ thì đó. Thì khi mình đặt cái stent vào, mình làm nó nhỏ lại. Đây là một cái ví dụ. Đây là cái hình, đây là một cái case của tôi, thì là nó thì rõ ràng mình thấy là cái LAD nó có một cái angle nó nối với lại cái left main nó là gần 90 độ. Và chỉ vì như vậy mình thấy rõ ràng là cái circumflex, cái ramus into cái ramus nó không có bị lesion gì hết. Và tại sao lesion nằm ở chỗ cái ostium của LAD? Là vì cái turbulence nằm ở đó. Thế thì bây giờ đây là cái trường hợp này là mới đặt cái wire thôi đó, thì nó đang làm cho cái góc nó nhỏ lại. Bây giờ đặt cái stent thì cái stent hoàn toàn thay đổi cái góc của cái natural angle of the LAD. Nó thay đổi cái góc của cái LAD. Thế thì câu hỏi mình là nếu mình làm như vậy có làm nhiều cái in-stent restenosis nhiều hơn không? Mình làm như vậy thì nó sẽ bị cái thrombus dễ nhiều hơn không? Thế thì đó là cái câu hỏi đó. Thế thì bây giờ tôi mới hỏi rằng là thế thì bây giờ mình làm xong rồi. Thế thì bây giờ cái bệnh nhân hỏi, đây là bệnh nhân là VIP đó nghe. Bệnh nhân hỏi, thế thì bây giờ làm xong rồi thì bây giờ sau này nó có tái hẹp hay không? Sao mình biết được? Thì nếu mà có thể cách là mình dùng iVerse, mình thấy rằng là cái surface area nó rất là rộng, thì không có sao hết. Rồi cái stent nó áp sát vào trong tường, nó không có bị hở thì nó tốt. Nhưng mà nếu bây giờ bên này cũng không phải lúc nào tôi cũng dùng cái iVerse hết, tại vì tốn giờ lắm, nó tốn giờ lắm. Thế thì bây giờ thì tôi cách làm như thế nào? Đó, đây là cái góc của nó, mình thấy rồi thấy không? Bây giờ cái hình số 2 thì mình sẽ thấy máu màu trắng ở ngoài đi vô. Đó, đây là cái hình số 2. Tiếp theo, bây giờ cái hình rõ ràng cái hình này thấy rằng là hình trước đây này, đó, thì máu nó còn đang ở mid của left main. Giờ cái máu nó đi qua nó đi tới một cái nữa, nó vô cái ramus trước, rồi nó tới circumflex, mà nó chỉ tới sơ của cái left main thôi, của cái LAD thôi. Chính vì vậy mà nó cause ra cái lesion. Giờ đi tiếp theo, đó, bây giờ mình thấy rằng là nó bị cái LAD nó bị rất là nhiều cái contrast màu đen nó nằm ở cái góc trong đó. Chính vì đó mà nó tạo ra cái lesion. Thế thì bây giờ mình đặt cái stent. Đó, mình đặt cái stent xong rồi. Đây là cái hình số 1. Đây là contrast. Hình số 2, nhìn máu đi vào. Máu vào rất là dễ và rất là tốt. Cái flow rất là tốt. Thì cái này chứng tỏ rằng là tôi nói rằng là cái bệnh nhân này, cái stent nó rất là tốt, nó không có bị, mà cái stent này đó là cái hình này, đó là cái hình 5 tháng sau đó, 5 months after, đúng rồi, 5. Thì tất nhiên là 5 tháng sau thì cái flow nó rất là tốt để có thể tránh được cái chuyện instant restenosis. Đó là một cái phương pháp mới mà tôi đang nghiên cứu để làm thử coi rằng là cái cách này để mà tránh cái instant restenosis. Thì cuối cùng lại, trong cái việc khi mà đưa ra cái nguyên tắc rằng là cái flow nó chảy theo cái flow nó chảy theo cái dòng chảy của nó, thì như vậy là rất là nguy hiểm nếu mà overdilated the side branch. Hiện nay mình vẫn có thắc mắc rằng là khi mình đặt cái stent ở side branch có đủ, làm thế nào có đủ chưa? Đó, tôi đưa một cái ví dụ. Cái hình phía trên đó là cách đây độ 3-4 năm đặt cái stent vào cái circumflex. Mấy năm sau nhìn lại thì cái lesion mà nó bị tắc đi, nó là cái ramus. Và nếu bây giờ mình đặt cái stent mà ở circumflex nó rộng quá, thì tất nhiên là nó lấy cái máu từ cái left main và LAD rồi qua circumflex, thì không còn máu ở cái chỗ của cái ramus intermedius nữa, thì tất nhiên là cái chỗ đó nó sẽ bị hẹp lại. Đó là một trong một cái áp dụng. Thành ra phải để ý là hiện nay vẫn thắc mắc là làm thế nào biết cái size của cái side branch mà mình không làm cho nó bị tái hẹp lại in the future. Cái số 2, bây giờ trong trường hợp này đó mình thấy rằng là cái turbulence nó do cái gì mà ra? Cái Reynolds number, V là tốc độ, D là diameter. Thế thì bây giờ nếu mà bây giờ một cái V là tốc độ, nếu một cái tốc độ mà nó nhỏ đi thì là cái số Reynolds number nó nhỏ lại. Reynolds number nó nhỏ lại thì là nó less turbulence. Thế thì V là thế bây giờ đây là một đây là cái diameter. Đây là một cái hình, một cái angiogram cách đây 10 năm. Cái đây hình bên phải, tôi đặt cái stent rồi, và đây là cái guide của nó là 6 French, tức là 2 mm, 3 mm. Thế thì thấy rằng là cái động mạch nó, cái LAD nó rộng lớn hơn cả cái guide này nữa. Thế thì 10 năm sau thì bây giờ lúc đấy giờ là làm lại, thì là đây là cái diagnostic catheter là 5 French. 5 French là cái diameter của nó là 1.63. Thì mình thấy rằng là cái LAD on beta blocker nó cũng nhỏ lại. Đó, thế thành ra vì vậy mà thấy rằng là cái beneficial mechanism of beta blockade is vasoconstriction of the LA of the artery, và như vậy nó làm less turbulence, và như vậy làm cho, chính vì vậy mà cái beta blocker prevents heart attack because it vasoconstricts the arteries and causes less turbulence. Đó là cái beneficial effect của cái beta blocker. Và cái nhìn trong cái này là tất nhiên là mình thấy rằng là khi mà làm angioplasty, sau khi mà làm angioplasty thì bệnh nhân lúc nào cũng phải có bên beta blocker. Và cái điểm số 2 là cái đây là cái speed, cái V là speed, thì thấy rằng là đây là cái hình 2011 thì cái RCA thì trong vòng 6 second thì là nó đến gần tới cái điểm của gần tới cái distal segment. Nhưng mà đến 2019 thì cũng 6.6 second, nó chỉ tới khúc giữa thôi, at the beginning of the distal segment. Thì như vậy đó thì thấy rằng là khi mà nó chạy chậm lại thì là nó làm cho cái less turbulence, và như vậy thì là cái đó là cái beneficial mechanism of beta blocker. Cuối cùng lại summary, hôm nay tôi muốn nói cái gì? Cái thứ nhất thì tôi nhấn lại là cái mà một trong những cái lý do mà tại sao có turbulence ở cái góc ngoài của cái ostium circumflex là do recirculation. Cái điểm thứ hai là nếu mà bây giờ đây là mình thấy rằng là nếu mà đây là cái dòng chảy cái bifurcation mà hướng tới antegrade thì cái lesion nó nằm ở phía bên ngoài của cái nhánh nhỏ. Nhưng mà nếu mà đi ngược lại, ví dụ bây giờ là cái này là ở distal RCA hay là distal circumflex hay là distal LAD, thì khi mà nó dòng chảy ngược lại thì cái lesion nó nằm cái chỗ của cái phía bên phải của cái nhánh lớn đó. Và đây cái hình này là cái hình quan trọng nhất trong cái bài này. Cái điểm số 3 thì tôi dặn lại là đừng do not over dilate the side branch. Cái điểm thứ 4 đó là khi mình làm xong rồi, mình làm một cái angioplasty xong rồi thì bây giờ mình chụp hình. Thì mình chụp hình mình xem rằng là cái nghiên cứu tôi đang làm đó là chụp hình để xem rằng là cái dòng chảy nó có lamina hay không. Nếu mà dòng chảy lamina là tất nhiên là in the future the chance for instant restenosis is much lower. Và cái điểm cuối cùng đó là về cái dùng beta blocker after PCI, if the speed is lower, if the diameter is lower, the chance for new lesion is much better. And thank you very much. Và statin cũng rất là quan trọng. Thank you very much for your attention.
Xin cảm ơn anh Thạch rất là nhiều. Không biết là bây giờ mình speak in English hay speak in Vietnamese. Hình như là các please.
I think that we should speak in Vietnamese.
Yeah. Cảm ơn anh Thạch. Thì bây giờ thì các chuyên gia nước ngoài hình như là cũng đi ngủ hết rồi. Bây giờ bên đó rất là khuya. Thì bây giờ đầu tiên là cảm ơn giáo sư Thạch Nguyễn cho chúng ta một cái bài rất là hay về cái cơ chế mà bệnh động mạch vành mà cơ chế mới. Chúng ta biết là lâu nay chúng ta học cái bệnh mạch vành CVD ấy, thì phần lớn mình là atherosclerosis, tức là CVD, tức là bệnh do xơ vữa động mạch vành. Và bệnh do xơ vữa động mạch vành thì thông thường là tạo cái mảng gọi là cái plaque burden từ cái atherosclerosis. Và như vậy thì mình học những cái statin mình điều trị, những cái antiplatelet, những cái thuốc điều trị xoay chung quanh cái mảng xơ vữa. Tuy nhiên thì cái lý thuyết, cái ý tưởng của giáo sư Thành Nguyễn nó rất là mới và nó rất là very new, very breaking, rất là đột phá, là giải thích cái việc mà tạo mảng xơ vữa từ cái thủy động học. Thì thật sự thì trước đây trong cái chúng ta học nó cũng có một đôi lúc người ta đã dùng cái khái niệm thủy động học này giải thích. Ví dụ như là cái stent, thì cái stent, cái strut, tức là cái thanh bên của stent á, cái thanh bên dày và cái thanh bên thin, mỏng, thì người ta lý luận rằng là cái thin strut thì cái dòng xoáy ở phía sau của cái thanh bên đó nó ít, thì nó ít gây ra cái hiện tượng là cái turbulence ở phía sau cái strut. Và các bạn biết là khi cái turbulence ở phía sau một cái thick strut nó dày á, thì nó tạo thành cái turbulence và nó sẽ làm bóc đi cái endothelium. Và khi nó bóc đi endothelium thì nó tạo cái cơ sở cho cái vấn đề tạo huyết khối. Vì chúng ta luôn nhớ rằng cái nội mô của mạch máu mình là cái endothelium phải bao phủ toàn bộ, và chính cái turbulence nó làm bóc endothelium và tạo huyết khối. Và như vậy thì những cái stent mà cái thanh bên nó dày thì nó sẽ tạo cái cơ sở tạo huyết khối nhiều hơn là cái thin strut. Thì như vậy thì cái cơ sở của thầy Thạch đưa ra là rất là dựa trên cái thủy động học, và trước đây mình cũng giải thích ở chỗ một cái carotid, cái hành cảnh á, cũng cái lý do tại sao mà nó hay tạo mảng xơ vữa ở động mạch cảnh trong. Thì như vậy đây là một cái cơ chế và một cái lý thuyết rất là mới để giải thích cho cái việc tạo mảng xơ vữa ở động mạch vành. Thì thật giải thích phía sau những cái chỗ bifurcation, phía những cái chỗ một uốn lượn mạch máu thì nó làm một cái tiền đề để tạo một cái mảng xơ vữa ở một số vị trí. Và cái việc điều trị như vậy là ngoài cái việc mà chúng ta điều trị là revascularization, chúng ta mở mạch máu ra, chúng ta dùng statin, chúng ta dùng antiplatelet, thì chúng ta còn có một cái hướng điều trị mới, đó là chúng ta điều chỉnh cái thủy động học, cái dòng chảy. Và chính như vậy thì cái việc mà chúng ta đặt stent ở những chỗ cái bifurcation, chúng ta thí dụ như là chúng ta đặt stent thì chúng ta đã sửa lại cái dòng từ một cái dòng chảy mà chia vuông, chia ra 3 nhánh và đi vào cái nhánh bên, đó là một cái gặp góc, thì cái đặt stent mình có thể nó là mở xuôi dòng chảy. Mà khi nói chuyện với giáo sư Thành Nguyễn thì mình dẫn câu chuyện hồi xưa người ta uống cái dòng sông, tức là có những cái dòng sông mà nó uống lượng nó gây những cái tàn phá, thì người ta lại uống dòng sông thành thẳng và mọi chuyện nó trở nên lại êm đềm. Thì đó là một cái bài rất là hay. Thì xin ý kiến của các thầy trong chủ tọa đoàn có tham luận hoặc là có ý kiến hoặc có câu hỏi gì cho giáo sư Thành Nguyễn trước khi chúng ta kết thúc.
Xin hỏi thầy Tập chút và mình khai pháo chút là xin hỏi thật là nếu như mà như vậy thì mình coi thử cái trứng có trước hay con gà có trước, có nghĩa là nếu như một bệnh nhân có cái giải phẫu mạch vành mà nó không thuận lợi, có nghĩa là cái carina nó đã theo một cái hướng ban đầu lúc mới sanh ra nó đã có rồi, như vậy thì những người đó có thể là bị bệnh mạch vành nhiều hơn người khác hay không? Thì tức là lắng động xơ vữa đó. Em muốn hỏi như vậy.
Thì bây giờ như vậy thì tôi đưa ra một cái research. Thế thì khi mà tôi nhìn, tôi dùng tất cả những cái khi mà tôi đặt tabulate, đặt những cái coronary arteries trong một cái danh sách đó, thì những cái bệnh nhân nào mà bị anomalous coronary origin of the RCA, bây giờ cậu về cậu coi lại tất cả những cái bệnh nhân mà bị cái bên right coronary artery, ít nhất là 25% là ostium anomalous. Ví dụ nó thẳng quá, hay là ví dụ nó nằm, nó bị anomalous, lúc bây giờ cái dòng chảy nó đi vào đó, nó bị trúc trắc thì nó gây ra lesion. Thành ra cái này rất là rõ ràng chứ không có gì lạ hết. Là quả trứng phải có trước. Sorry. Thì đó là một. Thế giờ cái chuyện thứ hai, thế hỏi là tại sao cái bệnh nhân nó lại bị cái lesion? Thì mình thấy rất là rõ ràng, cái dòng chảy nó bị collision nó có trước. Thì nếu cái bệnh nhân đó mà không có high cholesterol thì là không có lesion. Thành ra vì vậy một cái người bình thường ở Mỹ phải đến 50 tuổi họ mới có cái lesion, là tại vì cái collision nó đã có sẵn từ hồi mới đẻ rồi, thấy không? Thế nhưng mà lúc bây giờ cái đứa con nít đó, cái quả tim nó nhỏ quá, thì cái diameter nó nhỏ. Đây nhớ là cái luật của Reynolds, cái formula không? Diameter mà nhỏ thì không có turbulence. Điểm thứ hai, thế thì cái diameter nó còn nhỏ quá, đến người lớn mới bắt đầu có bệnh. Thế nhưng mà bây giờ cái khi mà có bệnh đó, thì cái tim của người nhỏ đó, người lớn đó, nó flexible, nó không gây ra cái turbulence. Và đến cái tuổi 50 á, nó bắt đầu cứng á, nó có turbulence. Đó, thì nằm cái chỗ đó. Thì câu đầu tiên là người nào sinh ra cũng có thể bị tim hết. Thành ra vì vậy mà không tập thể thao, nếu mà thì là sẽ bị. Thế bây giờ hỏi rằng là nếu tôi nói câu đó là người nào sinh ra cũng có thể bị bệnh tim hết, thì bây giờ đứa con nít nó bị bệnh tim rồi hay không? Có chứ. Nếu đứa con nít nó chỉ có là, nếu nó có cholesterol level 600, cái người bình thường của mình là 120, phải không? Và cái đứa bị cái gia truyền đó, bị cái hypercholesterolemia familial cholesterol level 600 thì mới 10 tuổi là đã có một cái lesion proximal circumflex rồi. Có 10 tuổi thôi. Là vì thành ra cái việc đầu tiên hết là collision, injury to the intima, xong đó là cholesterol LDL đi tạo ra một cái lớp vảy ở trên đó, rồi tạo ra như vậy đó thì mới là thành ra cái lesion đó. Thành ra vì vậy hỏi rằng là thành ra vì vậy người nào sinh ra cũng đều có bị hết. Thành ra vì vậy cái chuyện mà prevention with statin for low cholesterol một điều rất là phải làm. Thế bây giờ hỏi rằng là chính vì vậy mà chính là khi mà cái lesion nó bị cái injury như vậy nó calcification. Thành ra vì vậy mà làm cái CTA mà calcium level nhiều, làm angiogram, bao nhiêu người bị bệnh. Trong 30 năm mình ở đây, only one case, high calcium in the corneal arteries and has lesion. Người ta có high calcium là vì nó bị cái collision đó, nhưng mà nếu mà không có high cholesterol là không có bị. Đó là cái cách giải thích của mình, thấy không? Bây giờ theo thi các thầy khác thì giải thích như thế nào?
Dạ, cảm ơn anh Thạch.
Cảm ơn anh Thạch và cảm ơn câu hỏi của bác sĩ Hùng. Thì thật sự thì em nghĩ là cái bệnh động mạch vành và bệnh xơ vữa động mạch nó do rất là nhiều cơ chế. Và ngoài cái chuyện mà cái cơ chế mảng xơ vữa thì cái cơ chế thủy động học nó cũng sẽ tác động, nó tạo thành một cái lực, một cái vòng xoáy mà nó tác động lên cái mặt của endothelium của cái vùng mà nó tác động tới, và có thể nó là cái yếu tố thuận lợi để tạo mảng xơ vữa. Thành ra cái việc điều trị, thành ra cái việc điều trị ngoài cái chuyện mà mình điều trị nội khoa, cái chuyện đó là đương nhiên, thì em nghĩ rằng là sắp tới sau này nếu mà mình cái lý thuyết mình đưa ra mà chứng minh được từ lý thuyết cho đến cái vấn đề mà đưa ra một cái khuyến cáo thì nó cũng con đường nó còn lâu. Tuy nhiên có thể là sau này thí dụ trước một cái bifurcation từ Leitman đi vô circumflex và đi vô mũ với hai cái góc khác nhau, và khi mà cái lý thuyết này nó đã chứng minh được thì có khi sau này người ta sẽ khuyên mình rằng là mình nên đặt cái stent từ Leitman đi vào một bên nào đó thì nó sẽ tốt hơn đi vào phía bên kia để mình sửa là cái dòng chảy. Thì đó là cái hướng sau này. Còn đương nhiên là từ đây đến đó thì chắc cũng phải còn là chứng minh còn lâu. Như vậy thì cái cơ chế của thủy động học này nó không có bác bỏ với cái cơ chế của mảng xơ vữa, mà nó lại phối hợp với cái cơ chế mảng xơ vữa trong vấn đề điều trị.
Đúng.
Dạ. Thì em nghĩ là như vậy. Không biết là các thầy khác có ý kiến gì nữa không? Còn có câu hỏi gì?
Hỏi thầy Vũ đi.
Thầy Vũ.
Ý thầy Vũ sao?
Vũ có ý kiến gì mà Vũ?
Dạ, thưa thầy, thực sự là cái này thầy Thạch Nguyễn có nói thì đối với em nó cũng hơi mới. Em cũng không có biết nhiều về cái cũng có nghe về dòng chảy nhưng mà nghe một cách chi tiết và cơ chế rõ ràng giống như thầy trình bày thì em cũng chưa có được coi xem nhiều, cho nên thì em cũng không có ý kiến nhiều. Nhưng mà em nghĩ thì về dòng chảy chắc chắn là có đóng vai trò trong cái việc hình thành cái mảng xơ vữa, bởi vì ngoài những yếu tố nguy cơ tim mạch khác thì em nghĩ dòng chảy là vấn đề rất là đáng quan tâm. Dạ, em xin hết, em cảm ơn thầy.
Cảm ơn thầy Vũ. Mình tôi chỉ dặn thế này hôm nay để mình nói bằng tiếng Việt Nam, thấy không? Đó, we have to be the pioneer. You see? Hôm nay là rất là hay rồi đó. Phải nhớ nghe ông Pinto nói không? We want to learn from you. Vì technique bên Á Đông là phải giỏi hơn mình biết rồi. Nó chuyện bình thường. Đó, thành ra vì vậy mình phải là ngày xưa mình đi theo người ta mình học, khi mình học mình giỏi đó thì bây giờ mình phải có ý mới. Tại vì trong cái how to be successful in the US or in Vietnam, we have to have new ideas, provocative ideas. Chỉ đó đấy.
Chắc là bây giờ thì cũng đã đến giờ trưa kết thúc, thì giờ tối của bên Mỹ của anh Thạch và các cái chuyên gia nước ngoài. Dạ. Thì trước khi em kết luận và kết thúc bằng tiếng Việt thì chắc là đã chào Sandeep Nathan, nó biết ông còn thức hay không thì vẫn thấy trên cái cửa sổ. Yeah. Thank you so much. You have present until now. By now, yes, by now is the time for we close our very interesting virtual meeting. And on behalf of our organizing committee, on behalf of the co-chair, I would like to say some word to thank everybody. The first, I like to thank all the faculty, particularly the US faculty. In this time, it's very nice, about maybe midnight, but you still present with us to give the very excellent, wonderful presentation and to give lots of experience, opinion, comment to help us to understand more, particularly for the young interventionists in Vietnam. And to I like to say all the panelists, all the speakers have a very good, very excellent presentation to give some teaching point to the interventionist. And I would like to say all of participants in online, I don't know by now very maybe everybody hungry in Vietnam and maybe very few sleeping in the US. And I can summarize some work. We have the presentation from Dr. Michael Gibson talk about the triple anti-thrombic therapy versus the dual anti-thrombic therapy in the case with the atrial fibrillation in combination with acute coronary syndrome or after stenting. Recently now, the triple therapy or the role of triple therapy is reduced, and all the guidelines recommend is dual therapy is better, and by now become the class 1 in the recommendation of the guideline because it's reduce the bleeding high risk complication with the clinical outcome is similar. We have my presentation about the complex bifurcation of PCI in Vietnam. What are we doing now? And the next we have a presentation from Dr. Ngô Minh Hùng with the tip and trick for wiring into the very acute angle the vessel, tip and trick with a small balloon to obstruction unnecessary way. Direct the tip of wire go to the necessary vessel. Very excellent. And the presentation of the Dr. Yuan Pinto with demonstration 4, we use the intravascular imaging to guide for the guidance of the strategy of the PCI. And the presentation of Dr. Sandeep Nathan is very excellent about how we can perform the chip and the complex bifurcation PCI, the data from the new trial, and the instruction for instrument and equipment. We need the interventionist should be familiar with rotator, intravascular imaging, intravascular physiology, and particularly familiar with two-stand technique. And the last, the presentation from Professor Thạch Nguyễn, very excellent, very new and breaking idea, very new and breaking theory for the mechanism to form the lesion of coronary artery disease. So today, I think we can learn not only participants or the young interventionist, but myself and I think faculty can learn many things from your very excellent presentation and very excellent comment or discussion. So one more again, thank you everybody, and I hope I will see you again in the next session of the virtual meeting will hold by Vietnam Society of Interventional Cardiology in combination with faculty from America. Thank you so much, and the best wish to you, and stay safe in COVID-19 pandemic. Thank you so much.
Thank you very much.
Thank you. And
Cảm ơn thầy Thạch Nguyễn.
enjoy your lunch.
Tấm hình không thầy ơi?
Yes. Good night for the
Good night.
American
Sandeep. Good night.
faculty,
Okay.
and have a appetite for the faculty in Vietnam.
Okay. Thank you.
Yeah.
Bye.
See you again, Dr. Sandeep Nathan.
Bye bye. Thank you. It was an honor.
Thank you.
Bye.
Thank you. Bye bye.
Bye bye.
Bye thật.
Chào quý thầy.
Hỏi chụp hình chung không ạ?
Chụp hình chung không kìa?
Em chụp mấy tấm rồi anh Hùng ơi, em chụp mấy tấm.
Chụp
Dạ
rồi.
em chụp rồi.
Chụp rồi. Bye bye mọi người. Cảm ơn Thủy rất nhiều.
Chúc ăn trưa ngon. Cảm ơn mọi người đang tham dự chương trình.
Dạ, cảm ơn các thầy ạ.